Good afternoon, everyone. I'd like to call to order this hearing of the House Health, Finance, and Policy Committee. A quorum is present. Even though we don't have any of our minority members here in the room, I certainly hope that they will be coming to this very important hearing. But we do have a quorum nevertheless. A few items that I would like to mention as we get going here, just housekeeping matters. So this room is being prioritized for people who are actually planning to testify. And room 10 is the designated spillover space. And thank you so much to the Sergeant's office for working with us. As everyone can see, there's a lot of interest in this topic, and we're glad to have everyone here with us today. Also note that if you are in this room, you had a ticket to be in here. This is how we're doing the crowd control today. If you need to leave the room, you will need your ticket to get back in the room. So be sure you hold on to that ticket. Our plan today is we're going to move the bill, use regular procedures for that. And after we get through the presentation of the bill, we're going to take testimony from folks who have signed up beforehand. And quite a number of you have signed up to testify. And that's why, unfortunately, as the testifiers know, we can only give people 2 minutes to testify. I know that's a really short time. It's really hard to do, and I really apologize for that. But to be able to have this hearing in any reasonable amount of time, we must keep the testimony short. I also want to say that, as everybody knows, this is an important and emotional issue that we are going to be discussing today. There are strong feelings on all sides. In fact, I would venture to say that anybody who really thinks about this topic probably is going to have strong feelings about it one way or another. And that's why it's really important for us to remember that we're in a hearing situation. I just want to remind everyone that in the hearing room, we can't have any demonstrations or outbursts of any kind, and that includes clapping or making audible comments. So please be respectful of everyone. We want to give everyone a chance to talk about this very important issue, and we also want to get through it as expeditiously as possible and give everyone a chance. So with that, I am going to, since Representative Freiberg is the author of House File 1930 and he's not on the committee, I will move that House File 1930 be recommended to be re-referred to the Committee on Public Safety, Finance, and Policy. So, Representative Freiberg, if you would come up to the table. And there is a DE amendment that was posted, and that essentially replaces the bill. So the first order of business is to get the bill in the shape in which the author would like to have it discussed. So I'm going to move adoption of the DE1 amendment to put the bill in the form that he intends. So all in favor of adoption of the DE1-1 amendment, please say aye.
Aye.
Opposed?
Aye.
The motion prevails and the amendment is adopted. And then there is an author's amendment, the A2 amendment, which is just a technical amendment to the DE1-1 that we just adopted, and after we adopt that, Representative Freiberg can discuss the bill in the form he wants to. So I'm going to move the A2 amendment to the DE1-1. All in favor, please say aye.
Aye.
Opposed? Motion prevails, and that amendment is adopted. So we now have before us House File 1930 as amended, and with that, I'm going to call on Representative Freiberg to present the bill. Representative Freiberg.
Thank you, Madam Chair. Thank you, members of the committee, for being here for this really important piece of legislation. So before you is the End of Life Options Act. This is a bill that emphasizes personal autonomy at the end of life. I have heard very difficult stories from so many Minnesotans and some have dealt with loved ones dealing with unimaginable suffering. Some have terminal diseases themselves and want an option to end their suffering when it becomes unbearable. This bill will give them that option. So I'd like to summarize the bill and then ask three experts to testify and be available to answer questions. So the delete all amendment, which you just put in place, thank you for doing that, is the product of 9 years of feedback from Minnesota stakeholders, experience from other U.S. states, and research findings. So my intent is to balance the urgent need of dying Minnesotans and their families with legal and medical parameters that protect patients and providers. The main criteria for medical aid in dying have remained unchanged since I first introduced the bill in 2015. So to qualify for medical aid in dying, a person must be an adult, meaning they're 18 years of age or older. They must be diagnosed with a terminal illness with a prognosis of 6 months or less to live, and they are eligible for hospice. They have to have the mental capacity to make healthcare decisions and provide informed consent. So people with dementia will not qualify. And they have to have the ability to self-administer medication. So injections and infusions are prohibited. Additionally, 2 providers, at least one of whom must be a physician, one may be a nurse practitioner, must evaluate the patient and agree that they meet the qualifications. Both providers have to confirm that the patient is acting of their own volition and not subject to coercion. They have to inform the patient of all feasible end-of-life care options, including hospice and symptom management. They have to provide a referral to hospice if indicated. They have to explain all the risks and benefits. And they have to offer the patient the option to rescind the request at any time. Both providers must document the request in the medical record, and the attending provider must submit a request form signed by the patient and witnessed by a disinterested party. Medical aid in dying is patient-directed. So the new bill language in the delete all amendment you just adopted emphasizes that people do not qualify if they are subject to guardianship or conservatorship. It emphasizes that no individual is qualified solely because of an advanced age or disability, and a request may not be made by a guardian, conservator, surrogate decision maker, or healthcare proxy. Additional protections for providers are included in the revised bill. Healthcare providers have no duty to participate. Protections for patients are included in the revised bill. Criminal penalties are established for coercion. Now, just kind of to summarize before we get to the testimony, you'll hear a lot of really important testimony today. Medical aid in dying is supported by a majority of Minnesotans and Americans. Decades of data from Oregon and other states show that it is used by a narrow group of individuals with terminal illnesses, and that the safeguards in the bill are effective in ensuring that it is not used in situations where it shouldn't be. I'd like to thank everyone who has provided input on the bill. A special thank you to co-author Representative Heather Edelson, who is a strong supporter and has done a lot of work on the bill. So as part of the bill presentation, I'd like to turn it over to 3 testifiers, and I'm happy to stand for questions when the chair deems it appropriate. So the first testifier is sitting here with me. It's Nancy Uden.
Thank you, Representative Freiberg, and thank you for reminding me about that. So in order to allow the public to get through the public testimony, we have all these folks here today who want to testify. I'm going to ask members to please hold questions. All of the testifiers who are part of the presentation will be staying through the hearing, correct?
I believe so.
And so will be available. So I would ask members to hold questions until the public has had a chance to testify, and then we'll have time for debate and amendments and so on and questions. So thank you, Representative Freiberg. So welcome to the committee. If you would just state your name and go ahead and give us your testimony.
My name is Nancy Uden. My husband Jim and I live in Corcoran, Minnesota. This is my story and why I'm
ma'am,
testifying.
I'm having trouble hearing you, so if you could please pull your mic closer. I know we don't always have the best equipment, so you might need to adjust a little bit there.
My life changed. My life changed on November 30th, 2022, when I had a car accident caused by a seizure. I had no history of seizures, and I don't remember anything between the accident and waking up in North Memorial Hospital. After testing, they found I had a brain mass, and I asked for a referral to Mayo Clinic. They ultimately diagnosed me with glioblastoma. This is the most aggressive terminal brain cancer. Even with standard treatment care, it has a very grim prognosis with a median survival of 15 months. My family and I have endured brain surgery, radiation, chemotherapy, chemotherapy, and I currently use the Optune device 90% of the time to target cancer cells. But this is all treatment. It is not a cure. I promised my family that I would fight this ugly disease until there's no hope left and my death is inevitable. So if there are no more treatment options, then I deserve more death options. I'm not afraid of death, but I am afraid of how I will die. I walked my brother and my mother to the end of their lives over the past few years. They both died beautiful, painless deaths, and that's what I want. I had no choice of the cause of my death, and currently I have no choice over the slow and painful death that most glioblastoma patients endure. Our organs will slowly shut down and experience seizures, painful headaches, delirium, blindness, paralysis, and others. While I've always supported the idea of dying on one's own terms, it is now very real and urgent to me personally. I don't have time for long debates. This bill has been in front of the Minnesota legislature for 10 years already. It's time to act. As I imagine the end of my life, I would like to be able to say my goodbyes and go peacefully. I'm thankful that we have hospice as an option, and I will use it for maximum comfort. But if it is not enough in the end, I want the option to die gently in my sleep, just as my mother and brother did. I want to be surrounded by my lovely family. And not only do they want me to have the choices at the end of my life, but they also want to have choices at the end of their life, too. As a terminally ill patient, I beg you to do something now to provide compassionate choices to those who qualify, the ability to end their life peacefully and painlessly, surrounded by their loved ones. The safeguards of this bill are significant. There have been 0 reports of abuse in the 10 states in Washington, D.C., where this law has passed. And with that argument resolved, this should be a personal decision. The Minnesota legislature has made bodily autonomy a priority. Well, this is the final act of autonomy that any of us will have. I want to thank you for listening, and please, please, please pass the End of Life Options Act this year.
Thank you for your testimony. Next testifier, please.
Yep, thank you. I believe Dr. Carroll is next.
Welcome to the committee.
Thank you, Madam Chair. Chair Leemlig, members of the committee, thank you for allowing me to testify. My name is Dr. Corey Carroll. I'm an MD and board-certified family physician who practices in Fort Collins, Colorado. I'm also part-time medical director for Compassion and Choices, where I educate, support, and mentor physicians around the country who are incorporating medical aid in dying in their clinical practices. I continue to practice full-time medicine out of my solo family practice clinic. Over the 33 years I've practiced medicine, I've served as president of my local medical society, sat on the board of the Colorado Medical Society. I am currently a member of the board of directors of the Northern Colorado Medical Society, and I'm a member of the American Medical Association. At the American Academy of Family Physicians, I chair the member interest group that educates family docs about the medical standards of care for medical aid in dying. In 2016, the Colorado Medical Society withdrew its opposition to medical aid in dying that was adopted back in the 70s in favor of a position of engaged neutrality that respects diverse views. The Minnesota Medical Society adopted a similar policy of engaged neutrality in 2017. The intent of these changes was to protect the doctor-patient relationship and keep medicine where it belongs keep medicine where it belongs with patients, families, and clinicians. In 2018, the American Academy of Family Practice moved to a position of engaged neutrality on medical aid in dying. The following year, the American Medical Association affirmed that physicians could provide medical aid in dying, quote, according to the dictates of their conscience without violating their professional obligations. This is in the AMA Code of Medical Ethics. These changes reflect an accumulating body of research and experience that demonstrates that medical aid in dying laws are working as designed, infrequently, thoughtfully, and appropriately. As mentioned, Oregon has the longest track record with more than 2 decades of experience, and I'm sure you have, I hope you have that data in front of you as well as the Colorado data. Patients who request medical aid in dying have typically endured years, if not decades, of treatment for a chronic condition, and most are enrolled in hospice receiving maximal care because, as you heard, they have a prognosis of 6 months or less that has been given to them. This has been given to them by at least two physicians, if not countless more, who have concurred that they do have this terminal illness and they will likely be dead in 6 months. They have full decision-making capacity. They understand and appreciate their diagnoses and prognoses and consider all the options and have clearly and consistently communicated their wishes. They do not want to die, but have accepted their death is inevitable and want to avoid unnecessary suffering. Let me repeat that. They do not want to die, but have accepted that their death is inevitable. Data from Colorado is consistent with Oregon. The top 3 diagnoses qualifying for medical aid in dying are cancer, followed by neurologic diseases and cardiovascular diseases. There are others involved, but those are the top 3. Most terminal diseases have a predictable trajectory where each functional decline is a step closer to death. These patients don't want to die, but they are dying. They're seeking relief from their suffering they have, or worry their suffering will worsen in the final weeks of their lives. Data also shows that approximately 1 out of 3 individuals who qualify for medical aid in dying choose not to ingest the medication. 33% have qualified and do not take the medication. We can only speculate, but that fact demonstrates clearly that patients are in control and make the decisions for themselves. What we do know is that having the medication, even having the potential option for medical aid in dying, relieves fear and anxiety. With many patients at the end of life, there will be suffering. Allowing the patient the option to manage their suffering with medical aid in dying leads to improved quality of life, even if they never take it. Since passage of the law of Colorado, I've had the privilege to serve as the attending physician for 19 patients. For all but one, I've been at the bedside, with their permission and request, when they consumed the medication and watched as they peacefully transitioned from this life to the next, bathed in the love of their families and friends. These have been some of the most meaningful experiences as my role as a doctor. For one example, in 2022, I was contacted to clarify medical aid in dying for a patient diagnosed with glioblastoma, the same condition you heard from Nancy. Now, Henrietta was diagnosed in 2018. She knew the terrible prognosis, and she wanted to have access to medical aid in dying, but she had marvelous response to treatment. It's quite amazing she lived for another 4 years. But fast forward to 2022. Now she is having seizures, she's paralyzed, bedridden, and she knows this is not going well. She is desperate for medical aid in dying. I was able to qualify her with the consulting physician being her neurologist, and this is the great part. On the day, and this is the experience I've had with my patient, the day she chose to take the medications, her friends arranged a party, and it was filled with loved ones and friends and family to say goodbye and thank her for being on this planet. When I arrived, only close friends and family remained, and she took the medications with her 2 adult grandsons holding her and crying. She quietly went to sleep in a few minutes, and about 15 minutes later, she peacefully died and stopped breathing. The family thanked me profusely for helping Henrietta have a good death on her own terms. Helping patients with incurable disease facing a potential terrible death, medical aid in dying has enhanced my relationship to patients and their families. I appreciate what medicine can do, but medicine can't stop the inevitable. I took an oath to do no harm, but harm is also partially defined by the patient. My role as a healer is to provide comfort and support. Death is a part of life, and part of my job as a physician is to make that transition as peaceful as possible. In my view, withholding medical aid in dying especially within well-tested, well-delineated parameters, causes harm. Dr. Grube, a colleague and mentor of mine who helped me with when Colorado passed the law, has stated, if you pass this law, not one more person dies, but many less will suffer. I know that medical aid in dying isn't a new concept for at least this body, but for Minnesota, but there is no need to speculate. Medical aid in dying laws work as designed, and I'll be happy to answer any questions when the time comes. Thank you, Madam Chair.
Thank you very much for your testimony. And we have one more presenter.
Yes, Thaddeus Pope. Is it working? No, the system's not turning on. Speak loud.
Okay.
Does this work?
Test, test, test.
Yes.
Okay.
It's working a little.
Okay.
Yeah, it does work. It's just soft, so
really
you
close
might
to it.
need to be close to it. So,
Hello?
welcome.
I'll talk up.
Oh, sorry.
Please go ahead. Give us your name and
Oh, were you going to speak next, or?
So,
Oh,
do I step up?
yeah, you'll be called shortly. Sorry.
oh, sorry about that. Okay, so. Okay.
Sorry, it's a common look.
Yes.
Be careful. All right.
All right,
Chair
I'll-
Liebling, members of the committee, my name is Thaddeus Pope. I'm a professor at Mitchell Hamlin School of Law. And I've published 300 articles and 2 books on end-of-life decision-making. And I come to testify in favor of the bill in my personal capacity. This year, 50,000 Minnesotans will die, and many of them want to control the precise timing and manner of their death. Many already do, right, through withholding life-sustaining treatment, through withdrawing life-sustaining treatment, through palliative sedation, through VSED, voluntarily stopping eating and drinking. Medical aid in dying is just one more option, and it's an option with a proven and long track record. This bill is closely modeled on the 1994 Oregon Act, right, passed 30 years ago. In the last 3 decades, 9 other states and Washington, D.C. followed that model. And now 73 million Americans live in a jurisdiction with medical aid in dying. That's 1/4 of the country. And so today, we have 104 years of combined experience with medical aid in dying, with more than 15,000 patients. And that experience shows a solid patient safety track record. Why? Each state's Department of Health publishes an annual report describing who, when, where, and why patients use medical aid in dying. And a lot of researchers have done their own studies, and those have been published in peer-reviewed medical journals. And all of that data shows that these laws are working as intended, and there's no evidence of abuse. Indeed, while medical aid in dying has always been safe, today it's even safer. Since 2020, we have a professional medical society that offers training and CME and resources for clinicians. And the practice is robust, and there's established standard of care for everything from counseling to pharmacology. We don't need to speculate or hypothesize about the effects of this bill because it includes the very same elements as laws in 11 other jurisdictions. Now, we hear about laws in other countries, for example, in Europe, and those laws have changed their eligibility criteria. But that has never happened in the United States in any of the 11 jurisdictions. All the core elements have remained the same. They have not changed. In every U.S. jurisdiction, as Representative Freiberg presented, the patient must be terminally ill with a 6-month or less prognosis. They must have decision-making capacity. They must ingest the medications themselves. In the past 30 years, only 2 things have changed. One is the type of licensed clinician. So 3 states now permit APRNs in addition to physicians to participate in medical aid in dying, and that just follows the broader trend of expanding their scope of practice. And the second change is about the waiting period. Originally, the patient had to make 2 requests separated by 15 days. But substantial evidence showed that since patients don't seek medical aid in dying until very late in their disease process, that many died or lost capacity before the 15 days. So now most states have either shortened or permit waiver of the waiting period. Just one last point. Medical aid in dying is completely optional. It's optional for patients, for clinicians, and for healthcare entities. In the more than 100 years of combined experience with more than 15,000 patients, no patient got MAID who didn't want it, no clinician had to participate in MAID who didn't want to, and no entity had to participate in medical aid in dying that didn't want to. Medical aid in dying is opt-in only. Terminally ill Minnesota patients already control the timing and the manner of their death. Medical aid in dying is another important option, and it's one with a long and solid track record. Thank you.
Thank you very much for your testimony. Representative Freiberg, any final words to the initial presentation, or should we move to?
No, I appreciate the attention of all the members of this committee, so I think it's probably important to hear from the public at this point.
All right, well, thank you very much. So as you can all see, we have the video set up at the beginning, at the front of the room, and our plan here is to take testimony first from the people who are going to give us remote testimony, and then after we finish with that, we're going to have a brief pause, not a recess, but just a pause, so that
Recording stopped. Recording in progress.
so that the staff can remove the equipment from the room and get it out of the way. So hopefully we won't have computer voices talking at us randomly. So with that, then, I'm going to move to the first testifier, and that is Sarah McCumber.
Yes, thank you.
And thank you.
Rep.
Welcome to the committee.
Shirley,
And
committee members. My
just,
name is Sarah McCumber.
Ms. McCumber, can you hear me?
Work in Duluth, Minnesota. I have been an adult and geriatric primary care and family nurse practitioner for the past 23 years. And I specialize in working with adults and older adults with chronic life-limiting health conditions. And as many of the previous speakers spoke of, I have witnessed terminally ill, mentally competent adults suffer, and I fully support this bill, which allows these individuals to peacefully die in their sleep if their suffering becomes unbearable. As has been previously outlined, this bill follows laws and procedures that have been utilized very effectively in other jurisdictions for the past 25 years. And this bill is a very patient-centered approach which advanced practice nurses support for terminally ill individuals, giving them the ability to access the full range of end-of-life options. So I speak as an individual and as a nurse practitioner in strong support of this bill. I also would like to add that I know that a letter was submitted to your committee supporting from the Advanced Practice Nurses Coalition requesting that psychiatric certified nurse practitioners and psychiatric clinical nurse specialists be added to the definition of licensed mental health professionals under Section 2 definitions in statute. That addition is consistent with the Mental Health Uniform Service Standards Act, provider qualifications and scope of practice definition of a mental health professional. Thank you.
Thank you for your testimony. And before I move on, I wanted to just remind everyone that about the 2 minutes. And thank you. That testifier was just fine. I do want to note that we have a list of testifiers of people who've signed up, and the list is online, I guess. And if you have that, I hope please be aware of when your turn is coming up so we can move smoothly through this. And I do just want to remind everyone's been just great so far, but just to be respectful and make sure that we are respecting each other, no name calling, none of that kind of stuff, so we can hear everyone's point of view. Okay. That said, next one is Jean Bender for 2 minutes.
Chair Liebling, members of the committee, thank you for the opportunity to speak. My primary concern with this legislation is that our current healthcare system and workforce shortage are creating conditions that might lead a qualifying person to choose medical aid in dying to end their life. Their quality of life is diminished because of difficulty accessing necessary supports. And I have 3 examples, personal examples within the past year. In July, my son had spinal cord damage and subsequent spine surgery. Transition to home plan included in-home nursing, physical therapy, and occupational therapy. The day before his discharge, we were told none of those things were available, and I could bring him home without services nor the necessary equipment to lift, transfer, shower him, or they could find a nursing home placement. He's 37. He came home, he finally got equipment in October, but between July and October, I had to ask friends and neighbors to help me lift and transfer him. Because he's under guardianship, he would not be eligible for medical aid in dying, but this experience speaks to the difficulty accessing necessary services and supports. October, my dad, who was already dying from stage 4 kidney failure, had a major stroke, and our family was encouraged to consider a hospice at home or a nursing home. I personally met with the hospice personnel and set up services for my dad to go home with his wife. The plan was for hospice to meet medical transport at my dad's home, and equipment and training for transfers would be provided. Medical transport brought my dad home with no supports. Hospice agency didn't even visit until a full day later, and that was just to do paperwork. His wife had no training on how to move him nor change him. He was doing incontinent, nor did she have the medication to keep him comfortable, and she never got the promised transfer equipment because it was on loan to another hospice patient. He spent the rest of his time begging every visitor to get him out of bed to go to the bathroom, which was impossible without the equipment. He absolutely suffered, not because of his illness, but because of the promised supports were delayed or unavailable.
Ma'am, I'm so sorry. I have to ask you to finish here. Thank you very much for your testimony.
Can I have 15 more seconds?
I'm sorry, we're all over time. I really apologize, but thank you very much. Next person on the list is Suzanne Walford.
Thank you. I speak in total support of the Minnesota End of Life Options Act. I speak for myself, my family, and for thousands of Minnesotans in situations similar to my family's. But I speak especially for my 2 terminally ill sisters. Many chronic, terminally ill patients wish to petition for the right to end their suffering, as my 2 sisters fervently do. They desperately want to be granted the right to end their own lives, gaining dignity in death that has been lost under helpless long-term care and pain. Beyond our family's constant care and representing my sisters on bills like this one, we feel helpless to assist them in dying without making criminals of us all. It's all too much. Our sisters, our whole family, were stretched emotionally to the limit. Fortunately, Minnesota does not have to reinvent the wheel on this, as so many have said. Please learn from the 10 enlightened states and even 11 countries around the world who have successfully enacted medical assistance in dying laws similar to this one. These states have documented that the laws work. All they do is provide choice for the terminally ill. These states grant the right to choose to those who are rational but desperate to seek relief in death that has been forbidden to them. These states have found no evidence of the scary abuse scenarios playing out, as the professionals here have attested to today. Sick individuals there can take whatever path is right for them. We Americans are so proud of upholding the rights of the individual. Let us in Minnesota show some respect for dignity of the dying, the terminally ill, by granting them, not the state, the right to determine their fates. Thank you.
Thank you very much. Next is Anita Cameron. Welcome.
Good afternoon. I'm Anita Cameron. I'm Director of Minority Outreach for Not Dead Yet. It's a national grassroots disability organization opposed to medical discrimination, healthcare rationing, euthanasia, and assisted suicide. I'm testifying in opposition to HF 1930 because bills like this are dangerous to communities of color. So how do racial disparities in healthcare relate to assisted suicide? So researchers documented that Black, Asian, and Hispanic persons regularly experience barriers to palliative and hospice care utilization. A 2016 Journal of American Journal of Medical Association Internal Medicine study found that hospice patients were less likely to be visited by staff in their last 2 days of life if they were Black. Even more alarming, California nursing facilities with a higher number of Black and Latino residents have had higher rates of death. And although Black people and other people of color request assisted suicide less than white people at this point, as the practice is normalized, they're more risk of pressure to do so. So first, racial disparities in healthcare lead to limited health choices and poor health outcomes, including death. Economic disparities make it less likely that patients can afford life-saving treatment and more likely that doctors will write off patients as terminal and thus eligible for assisted suicide. Research also shows that Black patients are less likely to receive adequate pain treatment due to false beliefs about biological differences between Blacks and whites, which adds further pressure to seek assisted suicide. So as long as racial disparities in healthcare exist, legislation like HF 1930 has no place in Minnesota. So please vote no on all forms of this bill, and thank you for your attention.
Thank you for your testimony. Next, we have Kevin Bradley. Welcome to the committee.
Yes, thank you. I am here in two capacities. I happen to be serving as the communications director for the Libertarian Party of Minnesota, which supports this bill entirely because it gives individuals more control over their own lives, including the right to end that life on their own terms. Any Democrat who truly believes in the right to bodily autonomy should support this bill. Any Republican who truly believes government should have less control over our lives should support this bill. I am also an ordained minister with experience as a hospital and hospice chaplain. The right to die is also known as death with dignity. But many hospice professionals don't like that term because they believe hospice care provides death with dignity. However, it was not uncommon for hospice patients to tell me they did not consider their circumstances to be dignified. I believe the patient should have the right to decide what dignity means to them. Also, as another person recently said, hospice support is not always sufficient. If you want your death to come after days, weeks, or months of needless suffering, that's your choice. But there is nothing godly, compassionate, or righteous about forcing others to suffer. That's called being sadistic. If you are a Christian, you may know that crucifixion typically takes several days. Jesus reportedly said from the cross, "Father, why have you forsaken me?" His prayer was answered, as evidenced by the fact that he died in only 6 hours. The Father did not prolong the needless suffering of the Son. If you believe in a merciful God, you should be willing to let everyone avoid needless suffering. Thank you.
Thank you for your testimony. Lori Engel, welcome to the committee.
Hello, can you see me?
Yes, we can.
Okay, I am not very Zoom savvy here. I found out in October, I'm only 65, that I have incurable leukemia. I chose immediately to go on hospice, and I wish this bill could help me out. Unfortunately, I'm probably going to pass before this happens, but I'm lending my support because I feel it's so important that this bill move forward. And I also support the compassion and choices for their support on this bill. Thank you very much.
Thank you for your testimony. Mona Hinkles, welcome.
Thank you for your time. I speak in favor of this bill. I speak on behalf of a dear friend, Elfie Rice, a longtime Minnesotan who relocated to Washington State. She volunteered to help pass this issue in Washington, and years later, when she was diagnosed with pancreatic cancer, it was immediately a comfort to her knowing she would have this option if necessary. She fought valiantly for 4 years, and when she had exhausted all treatments, she exercised this option. She fought to live, helped by knowing she could be spared the worst. And when the worst was all that was left, this strong, independent woman, with her dignity still intact, chose to gather her family and beloved dogs in her own home overlooking Puget Sound and kindly and humanely leave this world. We all deserve to have the choice of this humane option. We all deserve to know that when our inevitable end is near, we can have the peace of knowing we can choose not to suffer further. Thank you for your consideration.
Thank you for your testimony. Joanne Roberts, welcome.
Thank you, members, and I appreciate being able to follow Mona because we have a similar story. My name is Dr. Joanne Roberts. In 2021, I retired after practicing hospice and palliative medicine in Everett, Washington for about 30 years. Throughout most of my career, I believed that physical, emotional, and spiritual pain could be successfully treated with the tools that we had, especially hospice. And so I was a very strong and vocal opponent when the Washington Death with Dignity Act was placed on the ballot in 2008. I am here today to share with you that I was wrong. The Washington experience since then and my own experience have changed my mind, and I stand in support of this bill, which is much like the Washington bill. In Washington, medical aid in dying has been used sparingly, compassionately, and thoughtfully. Every person enrolled in the program has complete agency in their decision-making, and each has an imminently terminal disease such as advanced cancer, ALS, and those kinds of diseases. In both Washington and Oregon, fewer than 0.5% of people who die through medical aid in dying, and more than 90% are on hospice when they die. And by the way, hospice utilization in Washington went up with the passage of the bill. Now I'm living with my own terminal disease, and it is likely my suffering will be brief and manageable so that hospice care will be sufficient. But as a person who now has death on my horizon, and having seen the law play out in other states, especially Washington, I should be able to make my own end-of-life choices, and I feel that Minnesotans should not be denied this safe and well-tested option anymore. Thank you.
Thank you for your testimony. Paul Bullard.
Hi, I'm here to support this bill. I started thinking about it because my father passed away in August of last year after being in hospice for 1 month. He was 90 years old. He had been in the Air Force and was an attorney, and he was suffering from complications from diabetes, coronary artery disease, congestive heart failure, chronic kidney disease, and he had recently suffered a stroke. On July 4th, 2023, he asked my sister and I to come down to the hospital. He let us know that he had made the decision to enter hospice care. I think he thought that he had made the decision, and when he was going to go off his insulin and his numerous medications, it would be a relatively quick process for him to pass. It was not, and our mother spent every day at the hospital from 7 a.m. to 7 p.m. And it took a toll on her as well. He did go to a facility eventually that took hospice, did hospice and took VA benefits, and they did their best to keep him comfortable. but during the night he fell out of bed on multiple occasions, and once my mom found him on the floor when she went to visit him. She was upset, and the next few weeks seemed like a few years. He passed away alone after my mom had left his side, and she felt terrible. She returned to his room the next morning and found that he had passed. And I don't know if she's ever going to get over that. Thank you.
Thank you for your testimony. And then finally, for the video presentations, we have A. Stuart Hansen. Welcome to the committee.
Chair Liebling and members of the committee, my name is Stuart Hansen, and I speak in favor of the House File 1930. I speak for myself, but I'm also a supporter of compassion and choices. I am a retired physician. I was a pulmonary doctor and critical care specialist in the Twin Cities for 49 years. During those 49 years, I estimate that I've had about 4,000 conversations with individuals about end of life and how they want to be treated, encouraging them to advance directives and to helping them in last weeks, months, and years. As a physician, my job was to cure and possible and to care always. At the end of life, when curing is not possible, then I enter the area of caring and caring as much as possible with giving relief of pain and suffering and some of the agonal processes of end of life. Skilled practitioners have pain and sedatives medications to use. Some patients, however, wish to remain in control, and we call that patient autonomy, and that I support strongly. Having the means and to maintain autonomy and to die with dignity is important to some people. Not all people take this choice, but if it is available, it relieves some of the anxiety of the end of life. This legislation will make those needs possible in Minnesota, as it has been made available in other states, as you've heard, and also in other developed countries. I urge the committee and the legislature to pass the End of Life Options Act, so Minnesotans will have more options at the end of their lives. Thank you for this opportunity to testify.
Thank you very much for your testimony. So that is the end of the list of people who are testifying by video. So we will just, as I said before, take a little pause. We're not in recess, but just allow the staff to move the equipment out of the room. So, folks, this should be only a couple of minutes, so I would ask everyone to please stay in your seats.
They just sent out
because we're going to pick up right again right away as soon as the equipment is moved. going to resume in one moment, and the next person on the list is going to be
That's a hard one.
Jean Swenson.
But more of the stuff we're doing right now is talking about what are sort of the basic rules of the road and parameters for usage, when to use it, when not to use it, how to use it within your organization. And a lot of states are doing this thing where they want all their public agencies to do inventories on where it's being used and how it's being used and so forth. Minute is already doing that. So, I mean, we could write a law for it, but Minute's already doing it. So, we don't necessarily need that. We're lucky. Minute's on top of the game, right? So, like, we don't need to write something for that. Somebody's like, well, why do you do that? Right. They're on it already without us telling you. So, because, you know, with the tab, we've been talking about it for a while, and they already saw it coming. So, Commissioner Holmes, Lesson, and John Israel, our CISO, they already started seeing the handwriting on the wall.
Could they just please have them send?
Although it could just be somebody might think you're saying something about it.
Very blessed.
Yeah, good eye. Yeah. Okay. Thank you.
I finally went to Rochester and got my whole plug.
Got a very good education.
So I have to go back for a test when we're done with session to see if everything looks good and all that. So yeah. But in the meantime, after I got done with that in December, my husband had a heart attack and ended up with triple bypass.
Testing 1, 2, 3, 4. Testing 1, 2, 3, 4, 5.
Wonderful. So, yeah.
Brandon, your
That's
lifesaver.
exactly right. No more.
Ready? Yeah.
All right, we weren't in recess. We are still in committee, so everyone please quiet down. Take your seats. I'm going to ask Jean Swenson, to come up. And so after Jean Swenson, we have Eileen Weber, Kathy Jo Ware, and Michelle Whitty. So please be ready to come up so that we can move along expeditiously. So Jean Swenson, welcome to the committee.
I thought there was a handheld mic. Is that true? Okay. Can you hear me?
We can if everyone is quiet. Please take your seats, folks. Everyone should be seated now.
My name is Jean Swenson, and I thank you for this opportunity. As a person with a disability, I have grave concerns about Age Up 1930. In 1980, I took a group of girls to hear a quadriplegic who painted beautifully by holding a paintbrush in her mouth. We were all impressed, but I remember telling the girls I could never live as a quadriplegic. Ironically, a few months later, I became paralyzed in a car accident. I spent the next year and a half in various hospitals and clinics learning to live as a quadriplegic. During that time, I fell into a deep depression, and I just wanted to die. But I'm so grateful that assisted suicide was not available and that those around me listened to me and then gave me what I really needed: good medical care, counseling, access to disability services, and lots of prayer and loving support. My life has not always been easy, but it's been good. I've enjoyed opportunities to teach, write, serve in various organizations, and develop meaningful relationships. I'm grateful to be alive. This law currently applies only to people with terminal illness. However, guidelines in other places have expanded from terminal illness to include people with disabilities. In Canada, Christine Gauthier, a paralyzed veteran requested a wheelchair ramp. Instead, she was told they could not provide a ramp, but they could offer her medical assistance in dying. I know all of you want to do the compassionate thing, so I respectfully ask that we pause and ask ourselves, once we open the door to this type of legislation, what will keep it from expanding in other places? When a person is facing overwhelming problems, we need to eliminate the problems, not the person. Thank you.
Thank you for your testimony. Oh, we've got good mics now. Eileen Weber, followed by Kathy Jo Ware, Michelle Whitty. Welcome to the committee.
Thank you. Thank you for holding this hearing and taking an important vote on this critical legislation that can impact every Minnesotan. For years as a nursing ethics professor, after years of caring for critically ill people, every semester I invited proponents and opponents of medical aid in dying to speak to undergraduate and graduate nursing students. Students posed thoughtful questions to both sides. I kept my position to myself. I wanted them to work through the issue. After debate and discussion, students voted on whether or not versions of the End-of-Life Options Act, which has been at the legislature since 2015, should become law. Without fail, they overwhelmingly recognize the autonomy of people who are dying, who want to but cannot escape their imminent death. They questioned why such a flawed healthcare system as the one we have should insist that people suffer instead of having the control they rightfully and reasonably request to decide when in their dying process they can self-administer the medicine that can shorten their suffering. Similarly, the nursing profession does not oppose laws like this as long as dying people with decision-making capacity who choose this option self-administer the medication. That is because nurses advocate for patients' autonomy, insist on ongoing informed consent, and because we do not abandon patients at the end of their lives. Among the most unfair and frankly disrespectful arguments pushed by opponents of this end-of-life option is to call it suicide. Patients who want this end-of-life option are not suicidal in the honest sense. They would rather live, but they can't have that wish. Impartial experts on true suicide at the American Association of Suicidology state unequivocally that suicide is not the same as medical aid in dying. Please respect the dignity, value, and autonomy of dying patients by allowing them this option if they so choose. Thank you.
Thank you for your testimony. Kathy Jo Ware, Michelle Whitty, and then Chris Masoglia. Kathy Jo Ware?
Yes.
Welcome to the committee.
Thank you. My 2 minutes doesn't start just yet, right? We'll get Kylan up here too.
Sure.
Thank you. Uh-oh, no, don't be grabby at stuff, okay? All right. Thank you, committee members. My name is Kathy Ware. This is Kylan Ware. He's my 29-year-old son. I am a registered nurse. I've been a registered nurse for 25 years, and we are both lifetime residents of the state of Minnesota. Assisted suicide is a disability rights issue and a disability justice issue. Assisted suicide re-weaponizes the medical community against people with disabilities. You are asking us to trust the medical community to dole out prescriptions for suicide without discrimination and to never stray from the guidelines. In Oregon, they provide assisted suicide because people feel like a burden to their families. They use undignified as an insult for the experience of incontinence. Incontinence does not equal an undignified life. And to believe it does fit the very definition of ableism. Minnesota currently has a catastrophic staffing crisis for both home care nurses and direct care staff. Minnesota needs to put their efforts into fixing the staffing crisis and providing supports for people with disabilities, not passing laws to have suicide prescriptions. Let's remember Willowbrook, the state institution where Geraldo did an expose on the inhumane, degrading, and violent abuse of adults and children with disabilities. The medical community, both doctors and nurses, ran those institutions. The institution didn't close until 1987. Let's not forget that either. Yet people with disabilities are supposed to have faith in this same medical community that less than 35 years ago told us to drop our kids off at that very institution and leave them there because it was better for them. As a disability rights advocate, I have fought for 30 years to get medical professionals and this community to look beyond Kylan's disabilities and his wheelchair and to see Kylan as a person who has value and worth and whose family fiercely loves him. And with the stroke of a pen, you want to undermine all that disability justice work. And you want to take power from our people and give it to others who can judge us as life unworthy of life.
Okay.
I beg you, please don't do that.
Thank you for your testimony. Michelle Whitty, then Chris Masoglia, then David Sturgeon, then Ed Klein. So Michelle Whitty, welcome to the committee. And folks,
Thank you.
please say your name as you begin your testimony. Thank you.
Yes, thank you, Representative Liebling and members of the House Finance and Policy Committee. I'm Michelle Whitty. I'm the Executive Director of the League of Women Voters of Minnesota, but I'm speaking here personally today in support of House File 1930 on behalf of my mom, Diane. Whew. She died after years of treatment for Parkinson's disease and months suffering with seizures and panic attacks after I took her into my home on hospice care. Most every day she would ask, when is this going to end? Why don't you just take me outside and shoot me? But as a Minnesotan and a daughter, I had no good choices to offer her. My 108-pound mother at that point took the only option she had, which was, thanks to information I found out from Compassionate Choices, she could refuse all food and water to end her suffering. And thankfully, we had help from hospice, but she lasted for 11 more days. Finally, she began to take those agonal breaths, those semi-conscious gasps for air that signal the end. My mother then spent her last days, 2 days, in this agonal state, and my father could not bear to sit by her bedside. So clearly, with the end in sight, we and her hospice and medical teams were not allowed to offer her the medicine that would have eased her final suffering sooner and allowed for sweet farewells, even though we had dozens and dozens of bottles of medication all around to try to keep her alive or well. She would say, "What do you have to help me die?" I hope you walk away with 2 points today, and it is so critical. This is Options Act, the end of life options. Anyone who does not want the option does not have to take it. No one, no patients, no families, no people with disabilities, no medical professionals are forced to violate their personal belief systems. This bill simply gives adults more humane options that my mother had, that we administered to ourselves. And death is a part of life. We should use medical science at the edge of death in the same way we do in life. We choose pain, aspirin for pain, chemotherapy for cancer patients, pain relief. This is about options. So please honor my mother's passing by passing House File, my mother's memory by passing House File 1930. And remember, legislators have few opportunities to alleviate real suffering, but you have the chance here today.
Thank you for your testimony. I'm Chris Masoglia, then David Sturgeon, Ed Klein, then James M. Hamilton. Welcome to the committee.
Good afternoon. My name is Chris Masoglia. I'm from Blaine, Minnesota, and I'm here today on behalf of my organization, Americans United for Life. We oppose Minnesota House File 1930, the End of Life Option Act. This bill, if passed, would legalize physician-assisted suicide, which would intentionally end human life. So intentionally ending a human life is wrong. It doesn't matter what name we call it. Suicide is not healthcare, and it's completely unnecessary due to the advancements in palliative and end-of-life care. This bill risks promoting additional suicide, despair, and hopelessness in our state. And what's even more concerning is that this law could be misused against vulnerable people groups, especially the elderly, the disabled, people of color, and the poor. The American Medical Association, the National Council of Disability, the National Council on Independent Living, the ARC of the United States, and many other prominent organizations all oppose assisted suicide. Activists promoting assisted suicide, organizations like Compassion and Choices, have been clever. First, they push laws with quote-unquote safeguards. And then when a state adopts those laws, those same lobbyists come in and lobby you to expand access. Just look at Oregon and Vermont, where suicide on demand is the law of the land. They even removed the residency requirement so people can come from out of state and receive death with dignity in that state. Statistics show that legalizing assisted suicide promotes and increases general suicide rates. Minnesota already faces suicide challenges. Look at our native reservations. Look at our military community. Look at places where they're dealing with youth suicide. Please reconsider this and support suicide prevention, not suicide assistance.
All right.
Thank you.
Thank you for your testimony. David Sturgeon, then Ed Klein, James Hamilton, Charles Dennis O'Hare. Welcome to the committee.
Thank you. This subject is very, very personal for me.
And please state your name.
David Sturgeon.
Thank you.
This subject is very, very personal to me. We all at some point will have our own end-of-life experience, our own end-of-life process. Medical aid in dying gives us some level of control over that inevitable process. It is an option we should all have given the right circumstances. Now allow me to briefly relate how I have personally witnessed a bad death and then a good death. First, my father in 2013, 98 years old, terminal cancer, skin cancer, bedridden in great discomfort, 24/7 bed care, bed sores, medications, on and on. Was he of sound mind? Could he make a rational decision? He offered to write his caregiver a letter of recommendation 2 days before his passing. He could make a decision. He begged me to take him to Oregon. He passed, choking on fluids, filling his lungs in great discomfort, with hospice at his side. Just the death he didn't want. Now jump ahead to December 22. My friend Tom had terminal heart disease in a rest home, bedbound, short of breath, heavily medicated, in hospice care, but living in California where they have medical aid in dying. After meeting all of California's strict protocols, he obtained his end-of-life medication to be used only if he decided. He picked a Monday in December, gathered his close family and a few friends. I was one of them. With his favorite music playing in the background, Tom said his goodbyes, that he loved us all, and took the medication. In a few minutes, he was asleep. In 20 minutes, he had passed. It was one of the most profound moments of my life to witness such a peaceful death, knowing this is what he wanted at the end of his life. Having witnessed these two deaths, I don't see how it's possible to deny one the option of medical aid in dying, given the right circumstances. I urge you to pass the Minnesota End-of-Life Options Act. Thank you.
Thank you for your testimony. Ed Klein? Okay, don't see. Are you Ed Klein?
No, I'm James Hamilton.
Okay, Mr. Hamilton, why don't you come on up? And if Ed Klein is out of the room and comes back, we'll squeeze him in. Okay.
Good
Welcome.
afternoon, Madam Chair, members of the committee. My name is James Hamilton. I testify today because I will not be here 1 year from now. I am dying from extensive small cell lung cancer, the same disease, the same incurable disease that killed my brother and devastated my family 15 years ago. I spent his final weeks at his bedside, doing what little I could to alleviate the suffering, the suffocation that he experienced as the disease ate away what remained of his lungs and wreaked havoc on his other organs. I do not wish the prolonged death that he experienced, nor do I wish my wife, my son, my siblings, my extended family, and my friends to weather the same storm. My brother's death scarred me, as you can see, just as my own death may scar those I love. Death need not be this ugly. Were the law to allow it, I would choose to end my life before this disease riddles my body and destroys my brain, as it did my brother's. As things stand, my options are to travel to another state for an extended period and die far from my family and friends, or as my mother did, to voluntarily stop eating and drinking and hope that I can maintain that through death. Many start, not all manage. It is only slightly less arduous than death by lung cancer in my experience. I ask you spare me and others like me from this fate by enacting HF 1930 as soon as possible. The time and manner of my death should be mine to decide.
Thank you so much for your testimony. Charles Dennis O'Hare, and then Ellen Kennedy, followed by Karen Charon. Welcome to the committee.
Thank you, Madam Chair and committee members. I am Dr. Dennis O'Hare. I am boarded in family medicine and geriatrics and work full-time caring for the elderly every day in assisted living and memory care units. That's where I was this morning. My recent roles include being a hospice medical director, an elected delegate from Minnesota to the American Medical Association, chair of the Ethics and Legal Committee of the Minnesota Medical Association, and prior to this, 9 years as vice president of medical affairs for Abbott Northwestern Hospital. In all of these situations, I have never encountered a patient request or desire for physician-assisted suicide. Never. We are here because some desire to legalize physician-assisted suicide in our state. It's about legalizing the ability for physicians to help our patients commit suicide by purposefully giving them enough drugs to die. The AMA spent years evaluating this, and in 2019, a supermajority of the 600 elected delegates from every state and specialty voted that the correct term is physician-assisted suicide, and assisting with this is fundamentally incompatible with the physician role as healer, would be difficult or impossible to control, and would pose serious societal risks. The previous physician testifier quoted the conscious rights section. This is not about pain control, it's about personal autonomy, but it's not autonomous. It requires physicians to become the gatekeeper of which suicides are supposedly acceptable. And this will affect those who are poor the most. The quiet voices they hear at night. Do I have value? Am I a burden? Is this a good decision? Becomes louder. Now their physicians and their states have said this is an acceptable option. Maybe I should do this too. I have patients every week on medical assistance, every week, who can't receive wound care because their insurance won't pay for it, but now will pay for them to get narcotics to commit suicide. This decision will affect all of us in our communities, and not in a way that will take us in a more caring direction. Please do not vote to approve this bill. The AMA is correct. Once you open this door, it becomes uncontrollable. That's why their language is so strong, as if saying, don't spread this. And don't change the incentive and commitment of physicians to care for them.
Thank you for your testimony. Ellen Kennedy, followed by Karen Charon, Angela Sovak, Kathy Blazer. Welcome to the committee.
Thank you, Madam Chair and committee members. I'm Dr. Ellen Kennedy. I'm the Executive Director of World Without Genocide, but I'm here to share a personal story. My husband, Dr. Lee Lawton, was smart and athletic, valedictorian of the College of Business at Valparaiso University, and a star on the swim team. He earned a PhD and spent 40 years as a professor teaching advanced statistics. He was athletic throughout his life, winning 50-mile bike rides even in his later years. In 2019, he began having terrible back pain. He was diagnosed with advanced multiple myeloma, an incurable blood cancer that eats away the bones. For 3 years, under wonderful care at the Mayo Clinic, he tried every option to stop the disease. A stem cell transplant and all 5 kinds of chemotherapy. Nothing worked. He was hospitalized 17 times. We spent several hundred days in Rochester. He had life-threatening drug reactions, including a seizure. He once spent 8 days in an ICU unconscious. He lost 6 inches in height as his bones collapsed. In November 2022, Mayo enrolled him in a new drug trial, a last-ditch effort. But when it was supposed to start, he was too sick, and he was hospitalized for extra care. A few days later, he was scheduled to begin. When I joined him at the hospital the morning of that first treatment, he told me that he had decided to decline it. He said that he no longer had any psychological or physical strength left. And we sat together and cried, knowing he would die soon. We had talked about death. He wanted to choose to die when the essential elements of his life, as he defined them, were no longer sustainable and viable. And he wanted to die then. But for 16 days, he endured the erosion of his personhood. The agony, the anguish, both his and mine, are beyond my words to describe.
I have to ask you to wrap up here. We're 2 minutes are done.
His final request was for me to support this bill so that people can end their lives when they are ready. Please honor this dying wish.
Thank you for your testimony. Karen Charon, and then Angela Sovak, Kathy Blazer, Eric Berg, Andy Aplikowski. Welcome to the committee. Please do state your name.
Good afternoon. My name is Karen Sharon, and I live in Rochester. I'm a Catholic, a nurse, a wife, and a mother of 4. People are a gift from God, from the unborn to the aged, the healthy and the sick. The Catechism of the Catholic Church says we are stewards, not owners, of the life that God has entrusted to us. It is not ours to dispose of. House File 1930 is horrific because it is not health care, it is death care. The AMA, American Medical Association, was quoted as saying physician-assisted suicide is fundamentally incompatible with the physician's role as healer. We cannot claim to be concerned with the mental health crisis and rise in suicides and at the same time promote helping someone die on purpose. Trying to legalize suicide by calling it medical aid in dying does not suddenly make it legitimate. Many of us have a fighting spirit. We don't give up. Why do people think that fighting to the end does not apply to illness? Instead of accelerating one's demise, we should look for ways to improve palliative care. Bill 1930 conveys that being ill is a burden and life has no meaning anymore. Instead, we should instill hope and give encouragement to the sick. Medical diagnoses can be wrong, and suicide cannot be undone. How can we justify possibly ending someone's life prematurely and depriving families of more time together? If we end life when it gets difficult, we miss important life lessons by facing hardship. Lastly, after experiencing the violating policies that completely destroyed informed consent during COVID, it is easy to see that no potential safeguards will be adequate to stop the inevitable abuses that will occur if you allow assisted suicide. Thank you for listening.
Thank you for your testimony. Angela Sovak. Welcome to the committee.
Thank you. My name is Angela Sovak. I support this bill because I have witnessed the relief hospice care can provide for most, but not all, dying patients. My grandma was amazing. She was outgoing, sarcastic. She loved playing cards with her friends and maybe having a little wine while she did it. On her 94th birthday, we found out she had only months left to live. When I asked if she was worried about the end, she said, "I'm not. I'm worried about being able to handle those last days leading up to the end. That's what I'm scared of." My grandma was not afraid of death. She was afraid of the dying process. Not knowing if this day or the next would be the day that it started, her fear kept her from enjoying her final days. Anxious and preoccupied, there were no more card games. She spent her time in her chair, quiet, eyes closed, not talking. On one of my visits, with tears, she asked me for aid in dying, not because of physical pain, but because of the mental anguish of not knowing if she would have a peaceful death. But I couldn't help her. Her dying process started 3 weeks later and took 5 days. She had to hold someone's hand at all times because she was scared. For days, she would look into my eyes, pleading with me, and I will never forget the sound of her voice saying, "Please, please." Hospice was managing her physical suffering as best they could, but there are other kinds of suffering. After 5 agonizing days, we had the gift of being with her when her heart stopped beating. But a better gift would have been months of connection and shared laughter instead of relentless anxiety. And that could have been possible if she knew she could have a peaceful death. She deserved to have that option. And every Minnesotan does too. Thank you.
Thank you for your testimony. Kathy Blazer, then Eric Berg, Andy Aplikowski, Cian Becker. Welcome to the committee.
Thank you, Madam Chair. I am here to testify against House File 1930. I am Kathy Blazer, Co-Executive Director of Minnesota Citizens Concern for Life. I have served as lead lobbyist with National Right to Life and MCCL on end-of-life issues, and as a member of the Minnesota Commission on End-of-Life Care. This bill would move Minnesota from a community of compassion to one of active, callous abandonment of our most vulnerable patients. When we move toward offering death as a solution to problems, we turn our backs on an actual cry for help and lose our incentive to solve the real root causes of that cry. Instead of improving palliative and hospice care, Minnesota will simply offer a deadly cocktail. Other states and nations have seen a consistent decrease in good palliative and hospice care after passing assisted suicide laws. Sadly, it's simpler and cheaper to offer deadly drugs than it is to create good, effective palliative care and hospice programs. Instead of offering good mental health care and walking alongside patients who are suffering from depression or anxiety, Minnesota will simply offer a deadly cocktail. We face an epidemic of loneliness and isolation, particularly among our elderly, disabled, and chronically and terminally ill patients. Instead of dealing with the underlying fears and anxieties hidden in a request for suicide, it is simpler and cheaper to acquiesce to the request, abandoning the patient to their feelings of burdensomeness and unwantedness. There are no safeguards or guardrails that can protect us from the dangers of any assisted suicide law. Every state, every nation that has passed assisted suicide laws has quickly moved to expand access and remove supposed safeguards. This bill moves Minnesota backwards, abandoning our most vulnerable patients, agreeing that they are a burden, and telling them their future is not worth living. Assisted suicide endangers every one of us. When the time comes, will we receive actual compassion and the help we need, or will we be offered a deadly cocktail of drugs that will not solve our problem, but will provide relief to those who pay the bills? Please vote against HF 1930. Thank you.
Thank you for your testimony. Eric Berg, followed by Andy Aplikowski, Cian Becker, Ray Parker. Welcome to the committee.
Thank you. My name is Eric Berg, and I'm a retired licensed psychologist, and I spent decades walking alongside people who are actively suicidal. But I wanted to share 2 brief stories of my family. My brother Chris died by suicide on May 2nd, 1997, in my parents' home in Vermont. He shot himself in the head. My mother found him when he did not come down for dinner. He'd suffered from untreated depression. He was an active alcoholic. He had a gun collection, a trifecta of vulnerability. This event was tragic in every sense of the word, heartrending to our entire family, and it continues to echo down the decades. Flashback now to early December 1989, same lovely country home, and I'm sitting in my parents' bedroom listening to my father's erratic breathing and groans of pain as he wavers in and out of sleep. He is in the latter stage of a melanoma that has metastasized to his liver, his lungs, his entire body. He is still able to limp to the bathroom. This is when I can see how shriveled his body is on one side, how swollen he is with tumors on the other. He is a shell of the strong father who raised me, of the 7-year Navy veteran from World War II. My father is in palliative care at home. He is in constant pain. When conscious, he talks mainly of wanting this be over, of wanting to die. I agreed it was a good day to die, a beautiful sun-on glittering snow day in Vermont. I prayed that he might die before I had to return to Minnesota. Such was not to be. Little did I know that he and my mother had planned for his demise after his years of battling different cancers, when his condition became terminal when he was ready. They had a compassionate doctor friend who gave my father what he would need when he felt he was ready to die. He was ready on December 17th, and after self-administration, died very peacefully in my mother's presence. But there was still tragedy. For one thing, it was all against the law, and that caused great worry for both my parents. The dying was a relief, as life, such as it was, had become intolerable. But the fact that my mother had to do this alone, that it had to be secretive to protect the rest of us, that we could not be present to say goodbye and usher my father on, this was the tragic part.
Yeah, I'm sorry.
Ending one's life by suicide is indeed a tragedy.
I have to ask you to.
Dying on your own terms when terminally ill, surrounded by those you love, peacefully with dignity, is a gift. That is why I support this bill. Thank you for your time. Sorry to run over.
For your testimony. Andy Aplikowski, followed by C. Becker, Ray Parker, and Catherine Kelly. Welcome to the committee.
Good afternoon. My name is Andy Aplikowski. I'm the Executive Director of Human Life Alliance. We should not give doctors who are trained to save lives a license to kill. I have personally experienced the pain and suffering that cancer and other incurable diseases can cause. But make no mistake, begging a doctor to prematurely kill someone you love or that complete stranger you think has no value to society is not compassionate. HF 1930, or physician-assisted suicide, exploits the suffering and preys on the vulnerable. HLA has heard from those battling chronic pain and illness, like Mark Davis Pickup from Canada, who lives with MS. They fear being marked for death because of their diagnosis or their condition. Now that physician-assisted suicide and euthanasia are legal in the country. Financial burdens and outside pressures will also drive many requests for physician-assisted suicide. Just over a year ago, professionals at a MAID seminar in Canada acknowledged they have patients who are seeking death simply because they are poor. Depression is another clear sign of vulnerability. Oregon, the first U.S. state to legalize physician-assisted suicide, has a suicide rate 40% higher than other states. Shockingly, 98% of those seeking physician-assisted suicide in Oregon were not even referred for a psychological evaluation. This isn't compassion. It's a dark message from our society that some lives are not worth caring for. Needing care and assistance from others does not mean that a person no longer has dignity or value. Safeguards will fail, and some of us will be thought of as disposable, not humans with an inherent right to simply live. HF 1930 will not lead to a society with a culture that values every life. Physician-assisted suicide will hurt our society by cheapening life, fueling suicide rates, and empowering abusers. HLA believes pain and suffering needs answers, love, and care, not suicide. True compassion offers healing support and hope. Please affirm life, not death. Oppose HF 1930. Find out more at humanlife.org. Citations are available in my written testimony. Thank you, Chair Liebling and committee members.
Thank you for your testimony. C. Becker, followed by Ray Parker, Catherine Kelly, and Karen Adante. Welcome to the committee.
Good afternoon, Madam Chair and committee members. My name is C. Becker. As a lifetime citizen of Minnesota, I fully support House File 1930, the End of Life Options Act for those with a terminal illness. I myself suffer from a debilitating permanent disability, so I know the difference between a disability and a terminal illness. I have secondary progressive multiple sclerosis. On June 17, 2005, I heard words from my father that I will never forget. He said, "Why can't I just fucking die?" He had access to plenty of morphine as he was on home hospice. That night, as we were getting ready to go to sleep, he told me that I better get plenty of rest as I would need it the next day. When I woke up the next morning, I immediately went to get his morning meds as I was his primary caregiver. When I attempted to put his nebulizer up to his mouth, he turned his head as if he was saying no. I then checked his blood oxygen saturation. It was only 53. I tried to get him to wake up, but he was unresponsive. I immediately called hospice, and they came out and verified that he was actively dying. I then called the rest of my family. They all came as quickly as they could. Even my mom, who had been divorced from my dad for over 20 years, came. This was on the day before Father's Day that year. While waiting for my family to get there, I read my Father's Day card to my dad. I had been told that the hearing was the last to go. I sure hope that he was able to hear my words to him. After the rest of my family got there, we all spent some private time with Dad saying our goodbyes and telling him how much we loved him. At 6:15 p.m. on June 18, 2005, my father, Gerald Jerome Becker, took his final breath. When I brought my dad home from the last care facility that he was at, I sat him down and told him, "Dad, I'm going to tell you this one time and one time only. If you get to the point where the suffering is unbearable, you have enough morphine here to let you go to sleep peacefully and no longer suffer." I don't know if he overdosed on the morphine, but if he did, I can't say that I blame him. He has suffered for far too long. Just walking from the living room to the bathroom in a small apartment was a great struggle for him. Nobody should have to suffer like he did. Thank you.
Thank you for your testimony. Ray Parker, then Catherine Kelly, Karen Adante, and Mindy Smith. Welcome to the committee.
Thank you. My name is Ray Parker from Rochester, Minnesota. I'm opposed to this bill for many reasons. The language here says the person must sign a paper that states they were not coerced into suicide. But what is coercion? Suggesting over and over that they should consider suicide, that they are a drain on everyone. There might not be personnel to take care of them. That, besides taking away hope, is coercion. This legislation is one of death. We know from past legislation that this is just the foot in the door to implement more death legislation. With 35% of Minnesota population living with at least one chronic disease, plus birth defects, debilitating injuries, and the aging, one may expect another amendment that changes the language from voluntary to mandatory suicides for the good of society. And who decides that good? Who lives? Who dies? How about the unwilling to work? Are they a drain on society? You are opening a Pandora box of evil. You are trying to play God. You are not God. So stop with the death suggestions, trying to make suicide normal, acceptable, easy, and embraceable. Just eat the apple. Oh yeah, that was another serpent. Don't let this evil into our laws and society. Minnesota deserves better.
Thank you for your testimony. Catherine Kelly, then Karen Adante, then Mindy Smith, then Nina Civula. Welcome.
Thank you. I think my name is Catherine Kelly, and I'm a professor of communication. And I appreciate the comment that was made a minute ago about words are very important in trying to look at this, and you folks have a job ahead of you that's pretty amazing. Physicians wouldn't kill me if I chose suicide. I would be killing me. I'm not terminally ill. I don't intend to go to the end of my life suffering in a way that made life for me watching people who I've loved too difficult. It's not that we're trying to have a law of murder or death, but it's that death is completely part of living. My mother died in 1967, and she had ovarian cancer, went through all the treatments, and then eventually had to be put in the hospital and wait, which is what we do when we have these terminal diseases. And in the waiting, she was able to push her own morphine and give it to her when she needed it, so at least that seemed very humane. But by the time she had come to the point where death was imminent, her temperature spiked. And in order, at that time, our medical society said, when your temperature goes up, we have to put you in a vat of ice so we can bring your temperature down. Not with any vision of the fact that she was not only a temperature going up, she was dying. She laid in ice, an ice bath, screaming until there was nothing left in her, and she died. I will not go that way. I don't want anyone to go that way, but I want us all to have a choice. I guess my time is up.
Yes.
I wish you all well.
Thank you. Thank you very much for your testimony. Karen Adante. Welcome to the committee.
Thank you. Hello, I'm Karen Adante from Mendota Heights, and I'm speaking in opposition to House File 1930. When I heard about this bill, I was deeply troubled. But then when I read the wording in it, I was horrified and I was heartbroken. This bill is not compassion, and it does not provide a so-called peaceful death. I'm concerned for our most vulnerable, including the disabled. I have been an advocate, friend, volunteer for people with disabilities, including sitting on the board of 2 disability nonprofits. I have also been at the bedside as 2 of my dear friends passed away after long illnesses. It horrifies me to imagine my friends being treated the way this bill requires. Upon learning they were dying of cancer and the other of a degenerative brain disease, they would need to be told one of their treatment options is to kill themselves. And I can't even believe I am using those words. This is not care, and this is not how a civilized society treats people. As for my friends with disabilities, they are so sweet and innocent and vulnerable. They could easily be manipulated and coerced. No one wants to be a burden, and a prognosis of a terminal illness is absolutely terrifying. But we need to be showering these people with love and kindness and compassion, assuring them that they will receive the best medical care possible and the best quality of life, because they matter to us and they're important to us. That is a peaceful death. There are no valid safeguards in this bill to prevent coercion and abuse, but the bill does provide a cost savings, and it puts each of us and our loved ones in danger of not receiving the health care we need when we need it most. Passing this bill sends only one message, and that is that we are abandoning our most vulnerable. It is ableism in its most extreme form. Please, I urge you, vote no.
Thank you for your testimony. Mindy Smith, then Nina Civula, then David Plimpton, then Jennifer Williams. Welcome to the committee.
Thank you. Hello, my name is Mindy Smith, and I am here today in support of the Minnesota End-of-Life Options Act. I fully support this law's intention to provide choices for those that have a terminal diagnosis. I was actively involved in my father's care as he struggled with ALS and was unable to make the choices that he wanted based on current state law. My father, an active, avid outdoorsman of 62 years young, full of life and hope, was given the blow of a devastating diagnosis full of dread and death in his near future. As I'm sure everyone here is aware, ALS is a terminal diagnosis and one that is certainly horrific for a 6'6" former college athlete who enjoyed life outdoors in the beauty of northern Minnesota with his wife, children, and grandchildren. His care was managed by a compassionate group of providers who could only offer physical and emotional support. No treatment, no medication, no care that could eliminate the pain, suffering, and emotional trauma this diagnosis brought to my father and our family. He wanted choices, so he researched how to end his own life without resorting to suicide, which he knew would devastate our family. He investigated moving to another state that had passed a right to die law, but realized time would likely run out. And then, very quickly, he was unable to move, and then unable to speak. The heart-wrenching statement he made to me and my sister was, "I waited too long." And then for months, he begged us to take his life for him. At first with words, then motions, finally with groans of, "Roll me over," pleading with us to help him smother. My father's death on Christmas morning that year was a gift for him and for us, because his suffering was finally over. However, he died alone in the middle of the night in a nursing home. His dream was to gather those that loved him, celebrate his life, and when the time was right for him, administer a medication to help him leave this earth on his terms, wrapped in loved ones' arms. The Minnesota End-of-Life Options Act would provide that choice and love and compassion for someone like my father. Thank you very much.
Thank you for your testimony. Nina Civula, then David Plimpton, Jennifer Williams, Jillian Nelson. Welcome to the committee.
Hi, I'm Nina Civila. Thank you for hearing my testimony. I am 38 years old. I have lived in Minnesota my entire life, and I suffer from depression with suicidal ideation. I have suffered from this for about 10 or so years. I don't know if anyone knows the pain and suffering that goes into this mental illness. I'm speaking out in opposition to it because every state and every country that has allowed this option has increased suicide rates, as mentioned in previous testimonies. You're telling people like me that suicide is an option, death is an option, because our suffering is too great. On March 17th of this year, Canada will allow mental illness alone be considered an option for MAID. I do not want the only reason I am alive today is because of my faith and because of my family and those who walk beside me. And sometimes in the deepest parts when I am deeply depressed, even with all the help I have, I want to die. But that is not an option. It should not be an option. That is not compassion. Please oppose this bill.
Thank you for your testimony. David Plimpton, Jennifer Williams, Jillian Nelson, Karen Miller. Welcome to the committee.
Chair Liebling and members of the committee, I'm David Plimpton, a retired physician who practiced internal medicine and gastroenterology at Abbott Northwestern Hospital for 40 years. I support the legislation before you, as I, unlike Dr. O'Hare, my colleague, I have had to deny requests for medical aid in dying made by suffering terminally ill patients. As a member of the Minnesota Medical Association, I served on the MMA 2016 Task Force on Physician Aid in Dying. After an exhaustive review of the facts, input from experts, experience from authorized state, and member surveys, the task force developed the current MMA policy, which the Board of Trustees authorized in 2017 and reaffirmed in 2022. According to that policy, the MMA respects that principled, ethical physicians can hold different and opposing views on medical aid in dying. Therefore, since preservation of the doctor-patient relationship is of the utmost importance, as long as appropriate guidelines are in place, the MMA will not oppose medical aid in dying. These guidelines include the following: must not compel physicians or patients to participate against their will, must limit the procedure to adults with terminal illnesses who have decision-making capacity, must self-administer the medication, must require mental health referral of patients with suspected psychological or psychiatric conditions, must provide legal protection for physicians who participate. The Minnesota End-of-Life Bill covers these concerns and honors the foundational principles of patient autonomy, informed consent, and beneficence. In the states where medical aid in dying is authorized, the law works as well as a law can work. Thank you.
Thank you for your testimony. Jennifer Williams, welcome to the committee.
Thank you. Greetings, committee members. My main name is Jennifer Williams, and I oppose the House File Bill 1930 for numerous reasons. I first started thinking about this as a nurse, but after hearing so many compelling and good arguments, I share many of the concerns about people being alone when they die. But things that I have not heard people talk about yet is this is a hypocritical bill in our current times of our opioid overdose crisis. This is another kind of opioid overdose, and this should not be supported. It is also an unnecessary bill because people with terminal diagnosis do really have a plethora of options for traditional pain medications, palliative care, and hospice. I do agree that there are serious problems with our medical system that need to be addressed, not encouraging death to fix the medical system. It's also, I have concerns for the people that are with that person administering the medication, and they don't have the support for that person that they loved just died. They're left alone to suffer. It must also be noted that prognosis is not a certainty. It is an educated guess. I have known many people as a nurse that die much quicker or live much longer than they were prognosed. You can go on hospice 2, 3, 4 times. There's no end just the prognosis is just an educated guess. Really, death is always a tragedy, and we should not encourage it. We should not allow it to be in law. And I know suicide, physician to suicide is not the term that's like to be used, but according to the dictionary, suicide is the act or instance of taking one's own life voluntarily and intentionally. Please do not pass this bill for the good and well-being of the people of the state of Minnesota. Thank you for your time and serious consideration.
Thank you for your testimony. Jillian Nelson, followed by Karen Miller, Marie Kaler, and Paul Post. Welcome to the committee.
Good afternoon, Chair Liebling and committee members. Many of you know me as a disability lobbyist, but today
your name.
I am here as Jillian Nelson, a daughter. I'm here to ask for your support for House File 1930. My dad is dying. He has end-stage COPD. He has been denied a lung transplant and has been living isolated in a group home for years. On November 1st, I got a call from my mom that I never expected to receive. My dad tried to kill himself, and he failed. He spent a month enduring extra pain to save his pills so that he could end his suffering for good, and he failed. Since then, he waits. He gasps for air. He has no companionship because of the risk of COVID, and he waits. He waits knowing his family is hurting, watching him struggle. He waits knowing there's only more pain and suffering ahead. And he waits knowing that he was ready on October 31st. My dad is a complicated person, and we have a complicated relationship. But he always taught me that what happened to my body was my choice, whether it was how a date treated me, what color I dyed my hair, or if I chose to carry children. My body was my choice. And now he is trapped in a body that is a nightmare every day with no choice. It is unjust. I ask for support for this bill because we all deserve a choice how we live and how we die when the end is inevitable. This is not a choice that people will come to lightly, but it is a choice that should be available. However, in offering this choice to end-of-life control, we need to be mindful that we are not backing people into this choice. We must make sure that as a state, alongside these thoughtful provisions to protect this policy from being abused, that we are also making sure we have services and supports available to people in end-of-life situations so that medical aid in dying isn't the only option. My dad is lucky. He has all the services and supports he needs to be as comfortable as medically possible, which is not terribly comfortable. He also deserves to have medical assistance to die when he chooses to. Thank you for your time.
Thank you for your testimony. Karen Miller, Marie Kaler, Paul Post, and then Christina Ogata. Welcome to the committee.
Thank you, Chair and committee members. My name is Karen Miller. Thank you for your time. Life is a sacred gift. Hubert H. Humphrey, a pro-life Democrat, once said, "The moral test of government is how it treats those who are in dawn of life, the children, how it treats those who are in the twilight of life, the aged, and how it treats those who are in the shadows of life, the sick, the needy, and the handicapped." Unfortunately, the governing majority in Minnesota is failing this test. As our government officials, you have lost sight of the truths that were self-evident to our founders in the Declaration of Independence, quote, that all men are created equal, that they are endowed by their Creator with certain unalienable rights, that among these are life, liberty, and the pursuit of happiness, that to secure these rights, governments are instituted among men. Your chief purpose is to secure the people's right to life, yet these bills only serve to erode that right. This bill refers to medical aid in dying as if helping someone to kill themselves is actually a positive form of care. Changing the name of something doesn't change what it is. Woe to those who call evil good and good evil. Changing man's laws in the state of Minnesota does not change God's laws. Our Creator, who gave us life, commands us, "Thou shalt not kill." Yet this bill, like the PRO Act, is literal government-sanctioned killing. By what authority do you act in legislating on life and death decisions? I appeal to your souls today. Be reconciled to God. One day you will stand accountable before Him. Just as Abel's blood cries out to God from the ground, so will the blood of every baby and elderly person whose life has been cut short cry out to God from the soil of Minnesota. God has set before you life and death. Now choose life that you and your children may live. Deuteronomy 30:19. Thank you for your time.
Thank you for your testimony. Marie Kaler? Welcome to the committee.
Thank you. My name is Marie Kaler. When I retired in 2021, I started reading all kinds of books on death and dying and listened to dozens of podcasts on the topic. This is not something most people who retire aspire to do. I then enrolled in training to become an end-of-life doula. I now have the great privilege of providing support to people during their end-of-life journey. You can learn a lot from people who are dying if you just listen to them. I firmly believe that for people with a terminal, life-limiting illness, the dying process should be theirs to control. Their wishes for how they die should be respected and allowed to unfold as they want. If they want extraordinary measures taken to save and extend their life, that should be their choice. On the other hand, if they want a more peaceful and controlled end to their life, that should be their choice. As a doula, it is not for me to dissuade patients. My role is to be non-judgmental, supportive, and compassionate. Individuals with the terminal diagnosis are already dying. We should honor their bodily autonomy to take charge of their dying process. After all, it's their final act. It is their death, not mine, not yours, not anyone else's. Please allow them the dignity to use medical aid in dying if that is their choice. I will close with this quote. It shouldn't be a privilege to die well. It should be a right. Thank you for your time.
Thank you for your testimony. Paul Post, then Christina Ogata, Teresa Collette, and then Douglas Bruce. Welcome to the committee.
Thank you for allowing me to testify. My name is Dr. Paul Post, and I'm a retired family physician, having practiced in the state of Minnesota for 37 years, currently consulting for several healthcare organizations. I'm testifying in opposition to this bill titled End of Life Option for Terminally Ill Adults and the amendment that was just passed earlier. This term end of life option is simply a euphemism for physician-assisted suicide. I oppose the legislation for 5 main reasons. 1, physician-assisted suicide is harmful to the physician-patient relationship, which is already strained for a variety of reasons. For centuries, physicians have had the primary role of healer. If I had to offer the option of assisted suicide, it would sow distrust in the relationship. If I offered assisted suicide as a treatment option, it would coerce patients into considering something that may have previously been unthinkable. The right to die will seem like a duty to die. Secondly, in my clinical judgment, there is never a case where assisted suicide is necessary to relieve pain, especially with advancements in palliative and hospice care. That leaves more questionable motives, such as feeling like a burden to family and society. Third, right of conscience concerns. The bill states that if the provider is unwilling to write the prescription for suicide, they must, upon request, transfer care to another provider who is willing to do so. This does not really protect the conscience rights of the primary provider, as they are still complicit in the act being accomplished. Fourth, the bill specifies physician suicide for terminal illness in adults. History shows us that in most of the countries in Europe and now in Canada that have legalized this practice have over time extended it to those with disabilities and to children. I'm concerned about the potential for misuse of this practice in those unable to give informed consent. And finally, one argument for the practice is that it will lead to lower general suicide rates, as has been previously testified. In fact, in all nations where this has been studied, it is associated with higher suicide rates. Is this because life is devalued? I urge you to oppose this bill. Thank you.
Thank you for your testimony. Christina Ogata, and then Teresa Collette, Douglas Bruce, and Elena Niehoff. Welcome to the committee.
Thank you.
Thank you, members and Chair Liebling, for investing this afternoon and beyond in this very important issue. My name is Christina Ogata. I testify in support of House File 1930, and I echo the testimony of others this afternoon and hear their stories and feel their stories and personally know their story. My brother was lucky enough to live in a state that has this bill on the books in New Mexico, and he made use of it 2 years ago, almost to the day, after suffering for years from multiple system atrophy, which is, as its name describes, when your entire set of systems in your body atrophy. They don't work anymore. So he could hardly talk. He could hardly swallow. He was hunched over to where his nose nearly met his knees. He was in great pain. He used this bill. We were all there with him. We had the party that others have spoken to. The most amazing and peaceful and wonderful time to witness and be part of someone's choice. And as he said, I've lost control of my life. Now let me control my death. You know, so far, I am a very lucky person. My biggest trauma in life was falling off the swing set and breaking my arm when I was 12. I play viola with the St. Paul Civic Symphony, and I invite you all to the Winter Carnival concert on Sunday, 2 o'clock in the afternoon, Landmark Center, to our semi-winter carnival, I guess, this year. I go with my trained therapy dog to visit memory care unit and to speak to patients there and give them some comfort to the extent that they can experience it. I have a full life, a lovely life. But you never know. Tomorrow, it could be you or your sister or your brother. Please vote to support this bill. Thank you.
Thank you for your testimony. Teresa Collette, then Douglas Bruce, Elena Niehoff, and Linda Warner. Welcome to the committee.
Madam Chairman, members of the committee, my name is Teresa Collette. I'm a law professor at the University of St. Thomas, where I direct the Pro-Life Center. I'm here to oppose this bill on numerous grounds, many of which are outlined in my written testimony. In my brief time before the committee, I'd like to raise just 2 important points. First, Oregon data, which is far more robust than Section 4D of this bill would provide Minnesotans, tells us that the vast majority of people who exercise the option of obtaining lethal doses of drugs do so because of concerns about not full participation in those activities that, in the words of the form, make life worth living, or because they're concerned about a loss of autonomy. Sixth in the list of possible reasons comes the avoidance of pain. The simple reality is today's medical facilities and devices and drugs can relieve almost every form of pain. This isn't about pain. This is about trying to control the last moment of death. We've heard some compelling stories today, and I don't deny that. A wise legislator just once told me, facts tell, but stories sell. I can understand the sympathy that we all feel. But I've walked with many people in those last moments of death, and I've grown and benefited from all of them. Most recently from my father-in-law, who endured years of Alzheimer's. He lost his capacity to control his bodily functions in certain ways. He lost his capacity to recognize us. And he lost his capacity to feed himself. And yet, our family grew and flourished and benefited because we were able to support him and love him until his final moments. I believe that this bill will discourage families for undertaking that hard journey. I believe it will discourage people from living to the last moment of their life, and I think it's very bad policy. The final point I want to make is, if you enact it, we will know nothing about the practice based on 4D. All we'll know is the number of patients who've requested it, but nothing else about their motivations, their demographics,
Thank you for
or
your
other important
testimony.
facts. Thank you.
Douglas Bruce, Elena Niehoff, Linda Warner, and Blessing Griswold.
Welcome to the committee.
Thank
Thank you, Madam Chair. My name is Douglas Bruce. I live in Bloomington, Minnesota. And my story comes with a healthcare conference for my mother in the care facility. A new physician had reviewed her healthcare directive, was familiar with her history and her medication. And in the process of that meeting, she indicated, well, you know, Doug, that the medication she's taking is not going to cure her. I said, well, thank you for that. I appreciate that. It sounds like I have something to talk to my mother about. And we had a conversation, and she decided not to continue to take her medication. She was able to die very nicely with family there, and it was a very good passing. Afterwards, the doctor said to me, you know, Doug, families usually want me to have that conversation. I looked at her and I said, I don't know how you could. That's none of your business. I appreciate your input and your knowledge, but that's not your decision. That's a family decision. That's not St. Paul's decision or Washington, D.C.'s decision. That's a family decision. This law, I believe very strongly, is about a very strong family legislation. I don't know. I know I am going to decide when I die and how I die. I don't know how you feel about that, if you want me to make that decision for you or not, but I would guess that maybe you don't. And in that case, then you do make my point. Please, pass this law.
Thank you for your testimony. Elena Niehoff, followed by Linda Warner, Blessing Griswold, and Audrey Kingstrom. Welcome to the committee.
Madam Chair and the committee members, my name is Elena Niehoff. I am from Rochester, Minnesota. I testify against the End-of-Life Option Act. Not only this legislation is cruel and ruthless, it is also in conflict with the federal law called Assisted Suicide Funding Restriction Act of 1997. Section 7, 145, E25, Subdivision 4, End-of-Life Option Act stated that the state and medical facilities plan to receive federal funding. But the federal law, H.R. 1003, Assisted Suicide Funding Restriction Act of 1997, prohibits the use of appropriated funds for 1. Causing or assisting in suicide, euthanasia, or mercy killing. 2. Compelling any person or entity to provide or fund any item, benefits, program, or service for such purposes. 3. Asserting or advocating illegal rights to cause or assist such actions. H.R. 1003 sets forth a list of programs and facilities to which the prohibition applies, including under the Social Security Act Title V, Maternal and Child Health Care Services, Title 18, Medicare, Title 19, Medicaid, Title 20, block grants to state for social services, the Public Health Service Act, the Indian Healthcare Improvement Act, and others. The federal law, H.R. 1003, is not amended. So please explain to me why there is a conflict. Personally, I believe in God's choice. Psalm 41:1, how blessed is he who considers the helpless. The Lord will deliver him in the day of trouble. The Lord will protect him and keep him alive. In his illness, you, Lord, restore him to health. Thank you for listening.
Thank you for your testimony. Linda Warner, then Blessing Griswold, Audrey Kingstrom, Jerry Kaiser. Do we have Linda Warner? Okay. All right. right, I don't see somebody coming forward for Linda Warner, so Blessing Griswold. Welcome to the committee.
Thank you, Madam Chair and members of the committee. My name is Blessing Griswold. I'm a lifelong Minnesotan, and I am here to ask you to oppose HF 1930. When people think of assisted suicide, I'm not who comes to mind. I'm young, I am a college student, I have no wheelchair, no hospital bed, and no visible disability. And yet, I am deeply concerned about the message that this bill sends about the value of my life and how it endangers people with experiences similar to mine. For the past 3 years, I have experienced daily migraines as a result of long COVID. Every day is an uphill battle, and yet I know that my life is worth living. My concern is that for others like me, especially people whose conditions are terminal, that battle may feel pointless. Daily pain takes a mental and emotional toll. Now, thousands of Minnesotans are looking to their representatives to give an opinion. Can a life, even a remainder of a life, be considered expendable? Can government really decide that the last 6 months of life are irrelevant? If a physically healthy person becomes suicidal, the first response of friends and family is to find help. Why should the terminally ill not be given this courtesy? In recent years, the United States has faced a mental health crisis, and suicide prevention has been a high priority. How can we expect to succeed if the law prioritizes some lives above others? It should appall us that suicide is being held up as a beacon of hope to the patients of fatal diagnoses. This is not a solution. This is not healthcare, and this certainly isn't compassion. My life is no less valuable than anybody else's because I experience daily suffering. No one should be told that their life is not worth living because of a diagnosis. The chronically and terminally ill deserve better than to be treated as expendable.
Thank you for your testimony. Audrey Kingstrom, and then Jerry Kaiser, and then Kathleen Rowlands.
Audrey Kingstrom from Humanist MN is ill, wasn't able to attend, so I got approval to represent our organization on her behalf. My name is Ellie Hayland. I'm the president of Humanist MN, which is a secular community for ethical living. On behalf of Humanist MN, I'm here to speak in support of the Minnesota End-of-Life Options Act. As humanists, we believe in individual autonomy and the right for people to make decisions about their own lives as long as they are not harming others. This includes the right to not prolong one's life in the face of unbearable or unnecessary suffering. Further, we do not believe in a higher power that directs our lives. As conscious, rational creatures, we're responsible for ourselves and to each other to help create a world where each can determine the course of their own lives and contribute to the well-being of all. We acknowledge and accept, however, the diversity of experiences, practices, and beliefs among people in society. Hence, we also champion the separation of religion and government. One person's or group's beliefs, religious or otherwise, should not dictate public policy, as some are trying to do here with medical aid in dying. In a diverse society like ours, people should be given the option to make end-of-life decisions based on their own values and beliefs. We see the End-of-Life Options Act as a humane and compassionate approach for people who are suffering as they near the end of their lives. We urge our state legislators to pass the End-of-Life Options Act this session and for Governor Walz to sign it so that each of us can maintain as much bodily autonomy as possible at the end of our lives. Thank you.
All right, thank you for your testimony. Jerry Kaiser, and then Kathleen Rowlands, followed by Patricia James and James Hamilton. Welcome to the committee.
Oops.
Oh, is he on there twice? Okay.
Good afternoon, ladies and gentlemen, Madam Chairman and members of the committee. My name is Jerry Kaiser. I'm a 78-year-old combat disabled, 100% combat disabled Vietnam veteran. I volunteered for 2 combat tours in Vietnam. I was honored to do that. I'm testifying against this particular program because I think it's going to hurt all the veterans community, and that's who I'm talking to. I was a squad leader, and I had a number of other crew chiefs and helicopters with me, and we had to pull guard duty just like everybody else. An infantry unit, that's what you do. Well, one of my young veterans was a 19-year-old kid who was had his childhood sweetheart send him a letter that she no longer wanted to have anything to do with him and that he is a baby killer. He was distressed beyond recognition. But he did his duty. So we were on guard duty. Unfortunately, the sergeant of the guard, against my request, put us in different bunkers. I being more experienced than the other one, he was going to be with another guy. Unfortunately, at sundown, he committed suicide. Now, what does that have to do with this particular program you're trying to get past? What it would do would put a whole nother group of veterans who are on the side of their mental health, on the downside. He did something that I couldn't stop, and I grieve for that every day. That was 52 years ago. And I have post-traumatic stress myself. I would never want to take my life. God gave me this life. He's given me so many special opportunities to help veterans not do anything like this. And if this bill is passed, you will see an increase of suicides in the veterans community as we go along.
Thank you for your
categorically think that this needs to be gone.
Thank you. Kathleen Rowlands, followed by Patricia James, and then Bilal Murad. Welcome.
Well, good afternoon. My name's Reverend Kathleen Rowlands. I'm serving as the interim senior minister at Unity Church Unitarian, St. Paul, Minnesota. I'm also speaking as part of our Association of Congregations who back in 1988 passed a general resolution in support of the right to self-determination in dying. And I urge your support for the Minnesota End of Life Options Act bill. This is not assisted suicide. I'm going to speak to you as a parish minister who has had the privilege of attending the deaths of many parishioners, colleagues, and friends. And I want to tell you a story about the tale of two deaths. The first is a parishioner. I'll call him John. He received a terminal diagnosis of lung cancer. His cancer had grown to the point where he was slowly suffocating to death and in great pain. He reached out to me, his minister, to ask for counseling about how he could end his life and end his suffering and that of his family. And together with his wife and children, John came to a decision to seek help from a network of supportive volunteers after many conversations. However, because we lived in a state whereby medical aid in dying was not offered, and because he did not want to put us in legal jeopardy, John undertook ending his life on his own. He died alone. He insisted we could not be there with him in his final moments, and the pain of that knowledge still lives with his widow to this day. The second story of death is similar to ones that you've heard about a colleague who lived in Oregon, who used medical aid in dying, who had the kind of death that she had preached about and spoken about and cared about and ministered to others about her entire life. Her children was there, her husband was there. We held her, sang her, and loved her into the mystery of death, which we know is beyond our comprehension. Passing this bill does not force anyone to make a choice that they don't want to. Instead, it allows for a person to be fully present in their last hour to their loved ones and to their God. May you have the compassion to allow any of us to do the same. Thank you.
Thank you for your testimony. Okay, Patricia James, followed by Bilal Murad and Jeff McComas.
Thank you, Lady
Welcome.
Chair, and to the committee. My name is Patricia James, and I am the health chair for the NAACP St. Paul chapter, and I am also a guardian over an individual. This individual that I'm guardian over, he took really sick, and he was incubated for over 30 days. And during this time, this period, I was asked to end his life because they said that he was suffering. And if you would give us permission, we would help him to pass away with compassion, is the word that they used. My response to that was, I want to do all that I can for him because I know that this is what he would want, to do all that could be done for him. And in doing so, if he passes after having all done for him, so be it. That is God's will. And so they had one meeting with me in regards to this, and then they had a second meeting. And each time, my response would be the same, that I would want for this individual to, if you remove him from off the incubator, if we could give him the oxygen to see how he does. If that does not work, if he could get the trach and then have a smaller tube through the trach to help him to breathe. In this time also, they told me that if you bring in people to visit him because this is his last days and he's not going to be here, his body is clearly stating that he's passing. And so I did. I brought individuals in, and then when I brought the people in to visit with him, his color came back. He woke up because at this time he was under lean sedation. He came back, he laughed, he smiled in the state of condition that he was in. To this day, this individual is no longer on the ventilator. They removed it. Another doctor came in and said, okay, I want to remove it. And then if that doesn't work, we'll give him the oxygen. If it doesn't work, we'll do the trach, and that's exactly what I wanted. This happened. This individual is living to this day, no longer on the ventilator, no longer on the feeding tube. And he said, thank you for doing that for me.
Thank you for your testimony. Dr. Bilal Murad, followed by Jeff McComas, followed by Francoise Willems-Shirley. Okay, I think Dr. Murad may not be here, so Jeff McComas.
Hello.
Welcome to the committee.
Thank you. My name is Jeff McComas, and I live in Woodbury with my wife and 2 children. Never imagined myself as a spokesman for legislation, but here I am. My story begins in September 2022. I was on a boys' weekend up north with my brothers, and I developed a bowel obstruction. Next 4 months of whirlwinds of tests, biopsies, CAT scans, MRIs, I ended up getting diagnosed with stage 4 incurable, inoperable metastatic adenocarcinoma of the small intestine. Since then, it spread to my entire belly and the peritoneum. 13 months ago, I was told I had 12 months to live. That news came as a pretty big shock to us all, of course, but we've worked through the stages. We're mostly at acceptance at this point for most days. I've been fortunate to have great care at Mayo, Minnesota Oncology. They've helped me maximize and optimize the time that I have left. With successful chemotherapy every 2 weeks, I've done 26 rounds so far. My most recent prognosis has me living into 2025. I'll take that. While the side effects of cancer and chemo can be difficult, I fight through them, try not to complain, try to make the best of the time I have left. But even with my awesome medical team, my options are limited. I'll never be cancer-free. I'll never be in remission. At some point, the chemo will stop being effective, and then my cancer will continue spreading. I don't want a long, painful, drawn-out end. I didn't pick this road, but I'm on it. And I want to decide when I've had enough. I never did really think about medical aid in dying before I got this. Does anyone? I'm frustrated by the fact Minnesota doesn't allow terminally ill people like me the option of a peaceful death. As we've heard, it's not a new idea. It's been around a long time. It's not a partisan issue. I'm a lifelong Republican. All my friends that are Republicans agree with me when I talk to them about this. There's only one guy, one friend, let's call him Paul. He's against it, and he's a Democrat. Every one of us is going to die. We all have a stake in the outcome here. I'm not here to convince anyone that my way of thinking is more right than theirs. I just want the freedom to decide for myself without the government interfering. So for us, it's very urgent, it's very personal. Thanks for your time.
Thank you for your testimony. Francoise Willems-Shirley, welcome to the committee. And after that will be Kim Deere and Sue Eckfeldt and Valerie Golden. Welcome to the committee.
Thank you. Good afternoon. My name is Francoise Willems-Shirley. My mom's name was Tony Willems, and she passed away from cancer in March of 2022. Over the years, I spent many doctor's appointments listening to her advocate for dying on her own terms, peacefully and without suffering, specifically asking for the choice of medical aid in dying. When we found out my mom had terminal cancer with no chance of survival, she chose to go to a hospice facility. At that point, had it been available, she would have chosen medical aid in dying. The end was near, and all that was left was more pain and suffering. Within a couple of days, she struggled to talk, move, eat, or drink, and her pain continued to increase. A few days into hospice, we were told the signs were there, that she was nearing the end, and we thought, thank God, her suffering is over. From there, it was another 4 weeks before she actually passed away. 4 weeks without food or water. 4 weeks of begging and pleading with medical staff to address my mom's suffering. 4 weeks of a living hell for her and for us all. We had been told by the doctors that a body can't survive without water for longer than 3 to 5 days. That may be true for many, but I'm here to tell you it was not true for my mom. What we lived those weeks can only be described as inhumane. Situations such as eating your lunch while your mom is literally decomposing in front of you. Her body convulsing while you take notes on the timing of those convulsions so you have proof that she is suffering in order to advocate for more medication became our normal. Witnessing and experiencing what we did left lifelong scars that still haunt us. Having a voice and a choice in how you live and in how you die should be a right for all Minnesotans. This is not about politics. It is about humanity, dignity, and love. What a gift to give our mom a peaceful passing might have been. Please have the fortitude, the courage, and the compassion to pass the Minnesota End of Life Options Act. Thank you for your time.
Thank you for your testimony. Kim Deere, then Sue Eckfeldt, Valerie Golden, Bill Amberg. Okay, Kim Deere, I don't see. Okay. Sue Eckfeldt. Welcome to the committee.
Thank you. My name is Sue Eckfeldt. I am a retired registered nurse and psychologist. I'm going to speak just a little bit about the protocol for eligibility for medical aid in dying. If either of the two medical professionals who certify that the person has a terminal illness with 6 months to live has concerns about that person's decision-making capacity, a referral is made to a mental health professional for evaluation. It's normal for someone in this situation to be sad, even to have periods of feeling despondent. However, being eligible for medical aid in dying is based on capacity to make an informed decision rather than mental health issues or diagnoses. Capacity is determined by 4 capabilities: understanding, appreciation, reasoning, and communication. The person must show an understanding that the diagnosis is terminal and the prognosis is 6 months. They must show an appreciation of likely consequences and outcomes of each treatment option available. They must indicate a reasonable ability to weigh the risks and benefits of these options related to their personal values and goals. Finally, they must be able to effectively communicate their choice verbally or by whatever means of communication is possible for them. Thank you.
Thank you for your testimony. Dr. Valerie Golden? And then we've got Bill Amberg and then Dr. Steve Girardeau. Welcome.
Thank you. Thank you for the opportunity to testify in front of you today. I speak as a medical mental health professional. I'm a clinical psychologist and in fervent support of this legislation. As a doctor, but also as a citizen, friend, neighbor, family member, I have seen far too much unnecessary pain and suffering senselessly endured in the final moments of life because there were not adequate end-of-life options available. I have also personally been present where a very close friend who died of cancer about a year ago and had moved to New Mexico was able to avail herself of those options in New Mexico of their death with dignity legislation. And it was an amazing experience. There were all kinds of precautions and interviews and checks and balances, but she died with dignity on her own terms, and she was ready, and there was no coercion, and it was really an honor and a privilege to be there with her when she passed. This legislation simply offers choice. It's not required that a dying person use it, and as you've heard, sometimes they don't. They get it and they don't. They don't have to. It's just available. But merely knowing that you can say, I've had enough, and and being able to end unbearable suffering if and when it becomes unbearable is simply civilized, humane, and the right thing to do. It's the difference between wasting all the time one has left being fearful and worried versus, feeling all right, that you'll have some modicum of control. Why should anyone be required to be in pain and abject fear in their final hours and days when this legislation can allow them peace of mind and a modicum of control over their inevitable death? It is not suicide. People who jumped from the World Trade Center on 9/11, they were not committing suicide. They were simply choosing whether to die by fire or to jump to their deaths. It was inevitable. It is not suicide. It is also not depression, as people have tested. Am I out of time?
Yes, I'm afraid so.
Sorry. Okay, freedom from worry may be the greatest gift you can give someone.
Thank you for your testimony. Okay, Bill Amberg, welcome to the committee. And then after Bill Amberg, we've got Dr. Girardeau, then we'll have Kimberly Horton and Jane Cowles. Welcome.
Okay, Madam Chair, members of the committee, I'm Bill Amberg, Amberg Law Office. I'm representing two clients here today. The first is the Minnesota Psychiatric Society. The first one up, Dr. Trangle, wasn't able to make it, so I'm standing in for him. Secondly, for the psychologist, Dr. Girardeau, he had to go. So I'll be speaking briefly. We've heard a lot of emotional testimony compelling on both sides of this. Our concerns, both of these clients, are more technical. You have a letter from both of them. And just briefly, the Minnesota Psychiatric Society has met with the proponents of the bill and expressed some technical concerns that we would like to see addressed in the bill. Kind of regarding capacity, it's kind of a sliding scale. You got a headache, here's some aspirin. Okay, this would be kind of the other end of the spectrum. And from the psychologist's perspective, some clarity about what kind of testing and assessments would be done. I appreciated that last testifier before, because I think that was the first time we've heard some clarity. Anyway, working with members of the committee and staff and other interested parties, were available for technical input on the bill that as it works through the process. So send your questions to me.
All right, thank you for your testimony. Okay, we're at Kimberly Horton, and then Jane Sage Cowles, and then Tom Albin, and then Carrie Framestead. So Kimberly Horton, welcome.
Thank you. Good afternoon. From the moment my mom was diagnosed with ovarian cancer at age 57, she chose life. She had a loving husband of 40 years, 2 daughters, 2 beautiful granddaughters, and she wanted to be with them. And through every excruciating surgery and chemo and radiation treatment and surgery again, she still chose life. She wanted to be here. But there came a moment for her, as we've heard from so many others, that life was no longer an option. It was definitive. The doctors let her know that there was nothing more they could do. There was no hope. She reluctantly accepted this. But it was not her choice to die. The cancer had decided that for her. Without the option to live, the only choice she could have hoped for was a peaceful death. She entered hospice with that hope in mind, but it was not enough. It was not enough to end her pain. And so after 5 years of a hard battle with cancer, she endured weeks of agonizing suffering and an agonizing death. The things I had to see and do for her during those last few weeks were things she never wanted me to see. But it's not just about me. She never wanted to experience those things. Until shortly before her death, my mother was fully mentally competent, and if it was legal, she would have chosen to end this unnecessary pain and suffering. My last memories of her could have been from the beautiful weekend my family spent with her together, loving her, taking care of her. But instead, they are from her last week when she was virtually unrecognizable to me and I to her, and she was in unending, excruciating pain. When this bill is passed, I want you all to know, those of you who are uncomfortable with this, you'd never have to choose it for yourselves, but I want the choice for me. Please give me that option. Thank you.
Thank you for your testimony. Jane Sage Kautz, then Tom Albin, Carrie Framestead, and Merle Green. Welcome to the committee.
Thank you, committee chair, committee members. My name is Jane Coles. I live in St. Paul, and I support the passage of House File 1930. I know I'm going to die. I just don't know when or how. If I have a disease and diagnosis that qualifies me to apply for medication to end my life, I want to have a prescription on hand. That will bring peace of mind, a sense of relief. If I determine I am no longer able to bear the pain and anguish of the disease, the options available. Today, I don't know if I would use that prescription. I know I want the option. I am the third generation of a family that has discussed the value of importance of autonomy and end-of-life living till the end with values, my values, having discussions with my medical team, and connection with my family and loved ones. I stand before you expressing the values and hopes of my parents, Sage and John Coles, who loved living in this state. They began discussing and educating the community for this legislation in the early 2000s. It is time for our elected officials to pass this bill into law, reflecting the values of a strong majority of citizens all over this state. Thank you for your time, open-mindedness, and thoughtful considerations. Please pass this bill.
Thank you for your testimony. Tom Albin. Welcome to the committee.
Thank you for giving me the opportunity to speak today. My name is Tom Albin. I live in South Minneapolis, where my wife and I have lived for almost 35 years and raised our two daughters. In late 2021, I started having trouble eating and speaking, and I'm an avid hockey player, which is why I'm wearing a hockey jersey. I started choking when drinking water, and I tried to yell out to a teammate, and I couldn't get the voice to come out. So I went to my doctor. 5 doctors, and 11 months later, I got a diagnosis of bulbar ALS. That means that my speech, swallowing, and lungs are affected first, and my lungs later. So I'm actually still playing on 2 hockey teams. As you can hear, my voice is strained and difficult. Eating is difficult and problematic. I have a feeding tube, which has been great. Anytime I lace up the skates, that's the biggest nod to life that I can imagine. I have a bunch of things I love. I'm taking a rock and roll history class at the U. I love life. ALS, however, is a long-term torture. I'm a victim. I have no say in what happened. It's coming for me, and there's no stopping it. But I want to have the ability to take over and say, that's it. I'm taking charge now, controlling my life. Dying by ALS is like dying in slow motion. I don't mind dying. It's the act of dying, which will take years. I don't want my family to be filled with traumatized memories of my prolonged death, me doped up on meds, not really myself. HF 1930 can take months of terrible pain and torture and turn it into, instead, a beautiful moment. And that's what I'm asking for. Thank you.
Thank you for your testimony. Carrie Framstead, followed by Merle Green, Mark Karen, Sarah Winkles. Welcome to the committee.
Thank you. Obviously, I'm in yellow. I'm in support of this bill. My name is Carrie Framstead, and I'm from Grand Marais. My wife, Monica Catherine Schleep, died 4 years ago from stage 4 pancreatic cancer. She was 55 years old and only lived 8 months after her diagnosis. Monica was a bright, shining star of light, love and compassion and respect for all beings. I cannot say for certain if she would have chosen this option of care in hospice, but what I do know is that she felt very strongly that any person facing their death in hospice care should have the right to choose. It is their decision, no one else's. Many can have different opinions, but it comes down to this one person making a decision and having the choice at the time that they need it. This bill clearly lays out very specific requirements, and it has safeguards in place to assure access to this option is allowed only for those who qualify. In 25 years, there have been no abuses. I lastly want to state that this end-of-life option is not and cannot be associated with suicide. Over 100 people a day in this country die by suicide. This is a very real crisis within our communities. So many individuals alone, isolated, with the inability to access supports, to receive help and answers to keep them living another day, to live past their crisis. My wife, Monica, lived as long as she possibly could. She died a painful death. This legislation allows the gift, a celebration of life for family and friends, to have the chance to say goodbye, to share memories and share their love for this person. It allows us a different experience with death and a process of grieving that allows the rest of us who are living to continue to love and go on. Thank you.
Thank you for your testimony. Merle Green, and then Mark Karen, Sarah Winkles, Margaret Oybrecken.
Good afternoon. My name is Merle Green. I live in St. Paul, and I've been an educator of adults for about the past 40 years. My mom died when she was 60. They gave her 6 months to a month and 18 months to live from brain cancer. And she died at 18 months, and she had a fairly comfortable death. And for that, we are very grateful. But we've heard the testimony of an awful lot of people who haven't had that fortunate experience. It's very unfortunate and unacceptable that people get inadequate hospice care, that proper equipment isn't available to people with disabilities, or that a health care plan would not cover wound care. Those are awful. But these shortcomings and the passage of an End-of-Life Options Act have nothing to do with one another. They are not mutually exclusive. There are 3 more issues I'd like to address if I have the time. One of them is concerns about moves against disabled people, against black and brown people, and against the slippery slope. And I'm going to cite some data, so I'm going to read. I was doing some research from Columbia University and NYU on national statistics for those who have used end-of-life care. And first of all, fears that end-of-life care would overwhelmingly be used on the poor, the uninsured, the uneducated, or racial or ethnic minorities has not materialized. Only 11% of the patients were uninsured. The users tended to be white, older, in their 70s or 80s, educated, diagnosed with cancer, and insured. The irony of this is that black and brown people are less likely to get access to end-of-life care if they want it. To address the, let me see what I got. Oh, well, there's that. Thank you. Thank you for your time.
Thank you for your testimony. Mark Karen, Sarah Winkles, Margaret Oybrecken, Andrea Anderson. Welcome to the committee.
Hello. My name is Mark Karan. I live in St. Paul. This is a photo of my dear friend, Marianne Turnbull. Marianne sat in this very same desk in 2019 when they had a hearing for the same issue back then. She was a passionate supporter of medical aid and dying. Marianne had terminal ovarian cancer. And so actually her daughter and her brother are here too. Her daughter's going to speak later. But I just want to skip to I got a phone call in March. We had a beautiful friendship. That's what I wanted to say. Well, in March of 21, she called me and she said she needed to go to the ER. So I took her to the ER, and that was very difficult. But that was the sort of the beginning of the last chapter for her last few months. So this was March of 21. At the end of March, we found she had an intestinal blockage, so she couldn't really eat past anymore. So between the end of March and the end of May, when she passed, is about 8 or 9 weeks, and her family did a wonderful job supporting her in hospice at home. And I just want to say, we don't know, it's only speculative whether she would have used medical aid in dying. She was a supporter, she wanted the option. But if she did take it, she would have been able to give her family, who did a great job, the gift, and her friends maybe, the gift of an event, of a death ceremony that was beautifully described earlier by someone. And that would have been just a wonderful gift Marianne could have given to her family and to have for herself too. But as it was a 9-week process for her family. So I just wanted to say that. Thank you.
Thank you for your testimony. Sarah Winkles, Margaret Oybrecken, Andrea Anderson, Penny Pergament. Welcome.
Thank you. Hello, my name is Sarah Winkles. I'm from Stacy, Minnesota. Thank you to the committee and for your service to the state of Minnesota. The bill before you, the Minnesota End of Life Options Act, which authorizes medical aid in dying for the terminally ill, is important to me. I want patients in the state of Minnesota to have options when they are diagnosed with a terminal disease. I've been a radiation therapist for over 20 years and have seen so many people with the cancer diagnosis struggle and suffer. For me, it is a personal choice that I want to have available for myself and for my family. I lost my mother to metastatic cancer in 1990 when I was 14. Just recently, having lost my mother-in-law to Alzheimer's. I watched both deteriorate and suffer. It would have been nice for them to have an option such as an End-of-Life Options Act. If I was diagnosed with a terminal condition, I would appreciate having the option to consider what this legislation offers, which is compassion, love, and most importantly, dignity. What better way to die from a life-ending disease than to plan your death and make the transition peacefully on your own terms, in alignment with your own values, priorities, and your own beliefs. We need to put our personal beliefs aside and think of the individual person and not pass our judgments to others. Thank you.
Thank you for your testimony. Margaret Oybrecken? Welcome.
Thank you. Good job on pronouncing that.
Thank you. I was thinking if I say it like 6 times and then it's wrong. So, good. Once.
Okay, I'm here today about my father. He was a World War II vet, a retired farmer, and a devout Christian. He didn't leave farming until he was 90, and it's because he was having so much trouble with his legs, and so he moved to a small house where my sister lives to be able to manage that. But he never stopped working, no matter how much pain he had, no matter what was going on, he had to work. It was just huge for him. And he suffered more and more. He had rheumatoid arthritis, the loss of being able to walk. His world just got smaller and smaller and smaller because he was also getting more deaf each day. And he was 97 years old, in November of 2021, he read about voluntarily stopping eating and drinking, and he did it. He talked to each of his 4 daughters, and each one of us, and said, you know, I just can't keep doing this. I just can't. I know what's ahead. I'm going to end up across over there in the nursing home where they have to change my diaper. I can't do this. And so he did that. It took him a week. I'm here because I would have liked to have seen him be able to do this by drinking something and being gone in a couple of hours instead of suffering some more. That week he suffered not eating and drinking. There are no protocols in Minnesota for it, so the nursing home was insisting on offering him food and drink until his 4 daughters wrote a letter and all signed it, said, leave him alone. Leave this man alone. He's choosing this. This is his choice. And I want to say this is my life. If I need this, I want to be able to have it. It's not your life. It's mine. Thank you.
Thank you for your testimony. Andrea Anderson, followed by Penny Pergament, Gary Wetterspan, and Stephanie Jurek. Welcome.
Thank you for letting
Welcome.
me speak. My name is Penny Pergament, and I'm a retired clinical psychologist. I am speaking in favor of the legislation, and while there's numerous disagreement as I'm sitting here and listening about a lot of things, the thing that I want to address specifically is the difference between suicide and medical aid in dying. There is an organization that deals specifically with suicide. That's what they do. And they say the American Association of Suicidology recognizes the practice of physician aid in dying as distinct from behavior that has ordinarily been described as suicide. The factors they say are suicide involves people who have treatable, reversible diseases. Their impairment in their thinking is part of what's pushing them. The patient wants to die. The goal of suicide is self-destruction. People who suicide find violent means for doing so, and many times it's isolated and it's impulsive. Whereas medical aid in dying has to do with people who are terminally ill, who are desperate to live, who have no hope, who have no treatment left to talk about, who are mentally capable, who are rational, who are making decisions. They want to stop having to die on this slow, miserable, horrible death that they have no control over. Thank you.
Thank you for your testimony. Gary Wetterspan? And then Stephanie Jurek and Julia Nottingham and Marty Rossman. Welcome to the committee.
Thank you for this opportunity. I'm editor of the online blog called the Good Death Society blog. And I'd like to share with you, you've heard that facts inform and stories sell. I'd like to offer some data-based background and context for this conversation. The good death is something we would all want, regardless of which side of the issue that we happen to be on. And I'd like to let you know about a meta-study of 34 different research projects trying to determine what is a good death, trying to define for the physicians and the medical institutions a standard of care to achieve a good death for patients. There were 34 studies, and this meta-study looked at thousands and thousands of respondents, put it all together, and the 3 points that came out repeatedly were, number 1, painless, number 2, peaceful, number 3, on my own terms. That means autonomy, some sense that you can control what happens to your own body, that you are in charge, that you have a choice. And that is supported as well by all the studies done by the state of Oregon. Autonomy comes up as number 1, number 2 every year in terms of what people feel like is important at that critical point. So, you know, stories sell, facts inform. I just wanted to give you a little bit of information. One more bit of information that might be useful to you is that a recent survey, public opinion survey here in Minnesota, showed that 7 out of 10 Minnesotans agree on this point. So I hope that you, as servants of the people, have the wisdom and the courage to make the right choice on this. Thank you.
Thank you for your testimony. Stephanie Jurek and Julia Nottingham, Marty Rossman, Paula Engel-King. Welcome to the committee.
Thank you. Good afternoon. My name is Stephanie Jurek, and I live in Webster, and I'm testifying in support of the Minnesota End of Life Option Act. My friend Bobby has ALS. For over 27 years, she has known she has ALS. 8 years before that, her symptoms started. She asked me to come with her and her family today to talk about my uncle who died a few years ago from ALS after only 8 months after his diagnosis. I was here in September 2019 with Bobby and her family, and I testified the day after I gave my uncle's eulogy. But I rewrote my speech last night to tell you that Bobby isn't here today. Her and her family are at Southdale Hospital. Bobby had 2 surgeries on Friday, and she has been in the hospital the last few days with flu-like symptoms. The doctors think related to the medication from her surgery. For years, I took care of Bobby, so we have a special relationship. We were friends long before I was her caregiver. She has done so much for the ALS community and for this bill to pass. She's been working on this for the last 10 years. She talked about wanting to move to other states to use the End of Life Option Act, but she didn't want to leave her family behind. So she has fought for this law for years in Minnesota so she could be here with her family when she takes her last breath. I think she has held on this long to make sure that she saw this to the end. It occurred to me today that you would see more people in yellow shirts here today, Bobby included, but the people who need this bill passed most are those suffering from the worst health conditions imaginable, and it is keeping them from being here in person. And of course, Bobby's family can't be here because they are with her at the hospital. Please pass this bill to help others' families avoid needless suffering. Thank you for your time.
Thank you for your testimony. Julia Nottingham, then Marty Rossman, Paula Engel-King, Lisa Mattson. Welcome to the committee.
Hello, committee. Thank you for your time. My name is Julia Nottingham. One thing that we all have in common in this room is that we will all die. This bill is providing the opportunity to change the way death is dealt with for terminally ill people and their families. Families in other states and countries have the option to have celebratory gatherings where they share stories, spiritual practices, and say their goodbyes and take their prescribed medication and end their life while being mentally and physically present. They get to feel it all, the good, the bad, laugh, cry, and say goodbye. Death is inevitable. This conscious way of dealing with death is opening a door for us as people to turn a traumatic situation into a healthy situation for all parties involved. My mother, Mary Ann Turnbull, sat here in 2019 and asked you to consider passing this bill so she would have the choice of medical aid in dying. She always said she didn't know if she would use the medication, but it would give her comfort and she would have less anxiety about the pain she would go through while she was actively dying in the very end. She was haunted by her own memories of watching her mother suffer for over 24 hours as she was actively dying. I now have memories of watching my mom die from VSED. That means to voluntarily stop eating and drinking. I had to watch my mom starve to death. That was the choice she was left with because in the end, she had multiple bowel obstructions, was unable to eat food, and her chemo treatments were no longer effective and surgery was not recommended. She fought ovarian cancer for 7 years. Society has accepted and is accustomed to a heavily medicated unconscious death. This bill in front of us today gives us the choice of having a painless, conscious death. We as Minnesotans can change the way terminally ill people die in our state. If this bill is passed, it would also help with secondary trauma that families, social workers, therapists, healthcare providers, and first responders are all exposed to when dealing with a terminally ill person's death. Thank you for your time.
Thank you for your testimony. Marty Rossman. Welcome.
Thank you. First, I want to thank you for this hearing. Thank you for your patience. Thank you for your attention. It's been a long day. It seems to me it's a marvelous demonstration of democracy, and I'm thrilled about what has happened here today. I'm Dr. Marty Rossman. I'm 87 years old, and I'm in fairly good health, and I'm active in the community. I have chronic lung infection, which is under control with medication and inhalers. But the prognosis for the future, especially for deterioration of my lungs, is not rosy in terms of hoping that my lungs will function well forever. When I'm eventually diagnosed with failing lungs and am routinely super short of breath and know I'll be miserable with no chance of improvement, only suffering, I hope the end of life option legislation will have passed so that I can have the comfort of knowing that I have a choice. And if I leave with one word, and I hope if you leave with one word from this hearing, that word is choice. Thank you.
Thank you so much. Paula Engelking, and then Dr. Lisa Matson, Melinda Matson, and Hunter Cantrell. Welcome.
Thank you. I never dreamed it would be this kind of a long day. I'm impressed with everyone on both sides of the issue. My name is Paula Engelking. I'm here in honor of Ann Yoder, my late great cousin. Ann loved her family, hiking outdoors, and a good craft beer. She raised her family here in Minnesota, and I am so grateful that she moved to Colorado a few years before she received an ALS diagnosis. Why am I glad? Well, you've probably heard, we've heard other people testifying that Colorado is one of the states that has death with dignity legislation modeled after the Oregon model. And I mean, she went downhill fast. There's no doubt about it. She was on hospice, and Ann feared choking to death more than anything. She didn't fear death. It would be a chance for her to see her mom and dad again. But she feared choking to death. You know, maybe at night her husband's asleep, her son and grandson asleep, not able to help her, and that she would die alone. When I went out with one of my sisters for a farewell visit 2 years ago, this next week, it was wonderful to get to see Ann and to tell her how much we loved her, to wish her good luck on her journey, and to tell her, I am so glad, I hope it works out for you to do this on your own terms. And her husband told me the reason that they were starting the process now was because in 2 months from then, Anne might not have been able to lift the pills to her mouth. And that's why they started the process. I am happy to report that Anne had a really good death. 2 weeks after I was there, she was with her family, her loved ones. It was wonderful. And I sure hope you'll pass this legislation for people like Anne, other people I know with ALS, and also for people like your former colleague, Senator Tomassoni.
Okay. Thank you.
Thank you very much.
Lisa Mattson, welcome. And then we've got Melinda Mattson, Hunter Cantrell, Louise Bonnock. Welcome.
Good afternoon, Madam Chair and committee members. My name is Dr. Lisa Mattson, and I'm speaking on behalf of myself in strong support of House File 1930. I wanted to clarify a few things that I'd heard from testimony and reading testimony last night. So just a few things about this bill that I'll run through quickly. First and foremost, please remember that this bill only applies to people with terminal, incurable, irreversible diseases who are likely to die within 6 months. It does not apply to people with chronic illness or people with mental health disease or the disabled. This bill also only applies to people who are mentally competent who ask for this option of their own free will. This is not an option that needs to be discussed by any physician. There is ample language in this bill to protect the autonomy of the patient and prevent others from interfering with their care. And for those who are concerned about the safeguards in this bill, I would encourage them to offer up stronger language. I think it's also important that we recognize that this bill does not negate the benefits of palliative care or hospice. These services provide a vital role for a vast majority of people with terminal illnesses, and they've been shown to improve the quality of life for many patients and their families, but not everyone. When it comes to death, we've heard several people talk about death as if it's a tragedy, but then we have other people who just consider it a part of life. The process of dying is different for everyone, depending on the disease they're dying from. They have other health issues, their age may play a role, their tolerance for pain, or their concept of quality of life may play a role in this decision. You have testimony that exemplifies a myriad of different death experiences, some good and some bad. There is no one right way to die, and we need to do what we can to meet the individual needs of our patients. This bill gives us an option, not a mandate, but an option for people who know they are going to be dying. Thank you very much.
Thank you for your testimony. Melinda Mattson, then Hunter Cantrell, Louise Bonnock, Hallie Vanny, and Rosie Gaston.
Hi, everybody. Hi. Thank you.
Madam Chair, committee members, my name is Melinda Mattson, and I am here on behalf of myself and the Mattson family in absolutely strong support of House File 1930. For the 5 years between 2013 and 2018, I was the more than full-time advocate for my parents as their bodies continued to defy them. Our mother asked me every day for over 2 years to kill her. She was miserable. She knew what was coming up was not going to get better. Life is a terminal condition, and we are all going to die. I'm guessing that most of us hope that when that time comes, we'll go to bed one night and just not wake up the next morning. I don't fear death. I fear the process of dying, of having nothing to look forward to in my life, uncontrollable pain, of drooling and wearing diapers that somebody else has to change. I don't want my family to sit on a death vigil for months on end waiting for me to go. Many people are desperate to avoid the suffering and indignities of a prolonged and inevitable death. Studies have shown that people with terminal illnesses, such as cancer, COPD, ischemic heart disease, strokes, neurological diseases like ALS, MS, Huntington's, or Parkinson's, are 2 to 3 times more likely to commit suicide by gun, hanging, or intentional drug overdose. These are traumatic ways to end one's life.
and have devastating impacts on family and friends, particularly if they are the ones who find them. We've all heard the argument that we treat our animals better than we treat our humans. In today's world, Travis may not have had to shoot Old Yeller. He would have probably called his vet, who could provide Old Yeller with medicine for a painless and swift death to put him out of his misery, and he would do that because it's considered more humane. I've never understood why we do that for our pets.
Okay, I'm sorry. We have to move on.
This bill provides people with another option. Please pass this bill to give people who are suffering another option for death.
Thank you. Thank you for your testimony.
Thank you so much.
Hunter Cantrell, and then Louise Bonnock, Hallie, Vanny, Rosie, Gaston, and Kathleen Oganovic. Welcome.
Thank you, Madam Chair, members of the committee. My name is Hunter Cantrell. I'm a retired state representative, first-year medical student, and cancer survivor as of 6 years last month. And I am giving this testimony today in honor of my friend and former constituent, Richard Seeger, who is a strong supporter of this measure, but who passed away a couple years ago in a car accident. I want to thank Chair Freiberg and all the co-authors for their work on this very complicated and, of course, very, emotionally complex piece of legislation. I know that this isn't an issue that's undertaken lightly. We as healthcare providers have a duty to do no harm and to alleviate the cause of human suffering to the greatest extent possible. As someone myself who has experienced a life-threatening illness from which I almost died due to a nearly fatal reaction to one of my chemotherapy drugs, I understand intimately what it is like to face your own deterioration and mortality. Toward the end of my treatment, I ended up in the ICU and was hospitalized for 10 days, unable to walk, unable to move, barely able to talk, and experienced what I can only describe as unabated agony. My illness stripped me of many aspects of my identity that I held dear as a 21-year-old. Thankfully, I recovered after a long and exhausting rehabilitation. But should that not have been the case, I should think that I would have explored the options laid out in this bill, not out of hopelessness, but as a merciful amelioration of pain. I love being alive and cancer-free. But every cancer survivor or person who experiences a serious life-threatening illness knows that we are on borrowed time and that every day is extra. I encourage you, members of the committee, please pass this bill. Thank you.
Thank you for your testimony. Louise Bonnock, welcome.
My name is Louise Bonach.
Sorry.
This is my husband, Joe Bonach. This is the place he chose to live. This is the place he chose to die. But we live in Minnesota, and there are no provisions for medical aid in dying when he died. So he died instead in a cold, sterile hospital room. For so long, he tried so hard to live. He had all the surgeries, the radiation, the chemo, and pills, pills, pills. He lived his entire life with the strength and dignity you could only wish to have. But in August of 2015, he had his last surgery where we were told the cancer had moved to the other side of his brain. He spent the rest of those months losing all of the things that made him who he was: golfing, curling, skiing, woodworking, playing cards, and finally even reading. His whole life, he was in control, but in the end, he couldn't die on his own terms. He was robbed of his choice to leave when he was ready. So instead, for 14 long, torturous days, his son and I watched him and watched his body, that body, die. And mark my words, there was no joy, there was no peace, and there was no revelations, only pain and suffering. The End of Life Options Act has respect for bodily autonomy, and it allows terminally ill adults the option and the peaceful death. It allows us to live with agency and humanity. My husband didn't have access to that medical aid in dying that this bill could provide for the terminally ill. He didn't have the comfort of knowing that medication could answer all of his prayers and let him die in peace. It's the uncertainty of not knowing that causes the stress and the worry. How bad can it really get? I urge you to support this bill.
Thank you for your testimony. Hallie Vanny? And then it'll be Rosie Gaston and Kathleen Oganovic and Michael Tedford. And we're getting toward the end here. Welcome to the committee.
Greetings, committee members. My name is Haley Vanny, and I will be testifying today in support of House File 1930. So when I was 16, I started to notice that I was losing my vision in my right eye. And thanks to the Minnesota healthcare system, I was promptly diagnosed with von Hippel-Lindau disease. And so for those of you who don't know, von Hippel-Lindau disease is a rare genetic disease that results in the growth of tumors throughout your body. So currently, the life expectancy for my disease is 49 years old. Now, that's not a perfect number, but I do think that it does depict that I will die of this disease at a younger age than my peers. But I think one of the pearls of having this disease is that I've really gotten to think about the way I want to live my life and my death from a really young age. And so I think as a result, when I do pass, I'm really confident in the fact that I will have lived my life with purpose and intent and be surrounded by people I love. So I know that I will die, and I am accepting of that. I think one thing that I am scared of is the current end-of-life care options that Minnesota has to offer. So I know what death looks like. I've seen and held loved ones' hands as they've taken their last breath, and I know that is not what I want for myself. So not passing this bill, this is not abstract. This will negatively impact people like me. This means, as a medical school student who's going to be a future physician, I will have worked tirelessly to support and provide care for people of Minnesota, but in my dying moments, I won't be supported and my life won't be honored. So I please ask that you pass this bill for community members like me. Thank you.
Thank you for your testimony. Rosie Gaston, Kathleen Oganovic, Michael Tedford, Peter Wyckoff, Walt Gordon. Welcome.
Thank you. I hope everybody has a really good self-care plan for their evening tonight. My name is Rosie Gaston, and I'm a hospice clinical social worker here in the Twin Cities. I first began studying medical aid in dying during my master's program, as it was the focus of my clinical research project, which went on to get published in a medical academic journal, resulting in speaking opportunities at both national and local levels. I have spent hundreds of hours of my life learning about MAID. I have also dedicated my career to supporting, educating, and advocating for individuals living with life-limiting conditions and those that love them the most. I believe in what hospice and palliative care provides. A mass majority of the time, we're able to manage the physical symptoms and support the emotional and physical journey that comes along with death and dying. I have also had a front row seat when this does not happen. Some diseases are horrific, and they rob people of a dignified and a peaceful death, no matter how skilled the medical team is. I am standing in front of you as a clinician who's counseled and supported hundreds of Minnesotans' deaths, who has held the hands and had the tough conversations, who's facilitated depression and suicide assessments to ensure my hospice patients get the mental health support that they need, who knows of patients taking their own lives in traumatic ways because they didn't have this option, who has consoled patients who didn't understand why this isn't an option, someone who's had countless of conversations with my colleagues who also passionately support this but can't be here today because they are caring for the patients of our community. As a social worker who stands proudly with the National Association of Social Workers in Minnesota, who also supports this legislation. And as a person who understands that this topic is emotionally complex, and we are allowed to have varying values surrounding this. But at the end of the day, this is about upholding and respecting Minnesotans' right to choose MAID. This is about compassion. And it's about trusting healthcare clinicians like me to implement this in a way that upholds our patients' autonomy and protects those who are vulnerable. So I'm asking you, actually I am begging you, as an end-of-life clinician on the front lines, as somebody who knows this deeply, please move this forward.
Thank you for your
Thank you.
testimony. Kathleen Oganovic, Michael Tedford, Peter Wyckoff, Walt Gordon. Welcome. Have I said your name wrong about
You
5
said it
times?
perfectly.
Oh,
I'm
good.
very
Thank
impressed. My name is Kathleen Oganovic. Good morning, or good afternoon. I'm here today to speak in support of the End-of-Life Options Act because I saw my mother suffer for 9 months in a hospital bed, having strangers change her diaper, and slowly losing weight. And she was a very independent woman who really took pride in her independence and taking care of herself and doing things independently. And then she couldn't. Everything that gave her joy, getting her hair done every week, having her nails done, looking nice, playing cards with her neighbors, everything was gone. And that when you lose those things, you do not have quality of life. And I don't want that for myself. When I hear people talk, a lot of the people who have spoken today aren't as close to death as some of the rest of us. I'm 70, and I can see this coming. And I do not want to have the last months of my life the way my mother did. Thank you.
Thank you for your testimony. Michael Tedford, Peter Wyckoff, Walt Gordon, Reverend Fred Hintz, and Janice Geigel. And that will be the end of our list. So welcome to the committee.
Chair Liebling, committee members, thank you for hearing my testimony. I'm Mike Tedford. I'm a head and neck surgeon. I worked at Abbott Northwestern Hospital with Dennis O'Hare, Dave Plimpton. I work with Lisa Matson at the MMA. I treat patients who have cancers above the collarbones, face, inside the nose, inside the sinuses, lip, tongue, mouth, throat, voice box, extending to the neck. Ooh, baby. You've heard the stories. My written testimony gives some detail, asking you to please consider the suffering beyond pain that patients suffer end of life. There's a story in my testimony about how tumors I treat erode the carotid artery and people die peacefully from a catastrophic bleed that's traumatizing for everyone, including the nurses who happen to be standing by. My patients have fungating lesions in their necks where the tumor has worked its way out of their throat through the skin. It weeps body fluids and blood and smells. One patient could not see his grandchildren at the end of his life because he did not want them to remember the smell in his house. Another patient had a tumor in his sinus that was treated with surgery, radiation, chemotherapy, not controlled, grew, pushed his eye out of alignment from the opposite eye, double vision, tumor coming through his cheek, pushed his teeth out of alignment so he couldn't chew. There's all kinds of suffering. You've heard it today. You've heard all that suffering. As much as we wish we could manage all this stuff, it just doesn't happen. I'd like to echo what Ms. Gaston said, looking each of you in the eye. Please do everything you can to pass this bill this year. This is not philosophical, hypothetical, theoretical. Minnesotans are living and dying every day. Please do it this year. Thank you for your attention. Thank you for this hard work.
Thank you for your testimony. Peter Wyckoff, then Walt Gordon, Reverend Fred Hintz, and Janice Geigel. Welcome.
Representative Liebling and members of the Minnesota House Health, Finance, and Policy Committee. I'm Peter Wyckoff, and I'm a retired clergy and founder and executive director of the Minnesota and Metropolitan Senior Federations. Yes, Tina, we go back a long ways. I'm here this afternoon to speak in favor of the Minnesota End-of-Life Options Act as revised. Proposed made state legislation is well-written and provides more than adequate safeguards, some would say too many safeguards, to make sure that is not misused. When I think of our efforts back, we testified, gosh, more than 2 decades ago in sponsor of living wills. We were successful in separating the Catholic Church from MCCO. And in the process of doing that, the Catholic Church has become a major leader in the hospice end-of-life movements. They have not seen the light, unfortunately, and still provide misinformation today. But I'm hopeful, and I think we have seen in more than 100 years of recorded history now that we have of this legislation being passed, that like our daughter who died of sarcoma cancer before she was 25, that you will pass this legislation and give people the options at the end of life. It has not been misused. This is not a slippery slope. The same arguments we had decades ago as we passed the living will legislation in this state, which has now become a national model. Thank you.
Thank you for your testimony. Good to see you. Walt Gordon? Okay, no Walt Gordon, I guess. And so Reverend Fred Hintz? Welcome.
Thank you very much for having me. Madam Chairman, members of the committee. My name is Pastor Fred Hintz. I'm a clergyman of the Lutheran Church Missouri Synod, but I sit here before you representing the Minnesota Alliance for Ethical Healthcare. That is a diverse coalition of over 60 organizations who stand together on 2 points. One is to oppose the legalization of physician-assisted suicide, and secondly, to advocate for a more robust and equitable system of palliative care. As Minnesotans, we consider our quality of life to be a high one. We're rightly proud of many things, not the least of which is that we feel safe in our communities. I come before you this afternoon, almost evening, because of the proposal before us today, I believe would in fact make our communities less safe for at least some of our citizens. In House File 1930, we have in effect a bill that would tell many of our citizens that their lives are not of equal value to others. Specifically, I mean Minnesotans with disabilities, people of color, the elderly, people with limited incomes, and others who will be sent a clear message through this legislation that somehow their life is inferior to that of others, and therefore they should consider whether it might be better off for all concerned if they are no longer among us. In the face of this kind of repulsive suggestion, it should come as no surprise that an organization like the Minnesota Alliance for Ethical Healthcare has come into being in order to give voice to this diverse group of people who each in their own way feel threatened by this legislation, as the state now toys with the dangerous idea that somehow it would serve some good to suggest that people have a life not worth living. I urge you to oppose this legislation.
Thank you for your testimony. Janice Geigel? Welcome to the committee.
Thank you.
Thanks for your patience.
My name is Janice Geigel, and I'm here in support of House Bill 1930. Excuse me. My husband of 44 years had ALS, and he chose to end his own life. Knowing what he did about this horrible neurological disease, he was determined to end his life before he lost all of his functioning or became totally dependent on others to care for him. This is not an impulsive decision. He told me, and he told our 3 children what he planned to do, and he attempted to prepare us in the most unselfish, loving way that he could. Unfortunately, his first attempt to end his life was unsuccessful, and so the nightmare of finding another method only made this journey more painful for all of us. Had there been an End-of-Life Options Act in place, my family would have had an opportunity to sit with him, to hold his hand, and support him with our love before he died. Unfortunately, he died alone, which losing him made it more painful for all of us. No family should have to experience what my family did. I urge you to pass this important legislation. I have told only a handful of people about the circumstances surrounding my husband's death because of my fear that he would be unfairly judged. However, today I'm choosing to go public with my story because of my passion to have the End-of-Life Option Act passed by the Minnesota legislature. Thank you.
Thank you for your testimony. So that concludes our list of testifiers. I just really want to thank everyone for your testimony, for your great patience, and for your wonderful comportment and respect for each other. It's been really inspiring to see that all around. So thank you so much. So now we are going to take up amendments. So now you may hear something from some of the committee members. So there are some amendments that have been filed, and there's an A3 amendment, and I wonder if anybody wants to offer the A3 amendment. Representative Backer moves the A3 amendment.
Yes, please,
Representative Backer.
Yep. What the let's get some voice it behind this here. What this amendment does is this will MDH will need to review all the reports submitted to the departments by providers for completeness, accuracy, and timeless. So that's what the amendment would do, and I would like to ask the author a question, if I may.
Representative Freiberg. Well, Representative Backer, go ahead, ask the question.
Okay, good, thank you. And maybe I'll share a little bit before I do this, but I would really would like you to consider this as a friendly amendment, accept this as a friendly amendment. And the reason being is if this is going to become law, I think it's something that is very important for MDA to review all the deaths that happens through this type of bill. And I'll just use an example. I serve, as many of you know, serve as an EMT, and we talked, this morning I talked to the executive director, and it is not uncommon that in the state of Minnesota there are thousands and thousands of runs just in a week's period. And they review every report. Now, they don't open and review every report, but they have a system that they look at the numbers, they look at how many EMTs, for example, 50% of all EMT-based BLS services are covered by a small group of EMTs because they're taking most of the calls. And, you know, we heard from several testifiers, and also I have some data here too that we have, like in Oregon, for example, in Oregon, 431 people were prescribed assisted suicide drugs in 2022, resulting in 278 deaths. In California, there was 1,270 people prescribed and 853 deaths. I think it just is reasonable that if we're going to have this, we should have that data. We have that data for us EMS paramedics when we call on life-saving runs and people are asking us to provide life care. This here is ending a life, and we should have the same type of data to do that. So I really would like the author to accept that as a friendly amendment. Is wondering if you would, and if you have any questions for me there, Representative.
Representative Freiberg.
Thank you, Chair. Thank you, Representative Backer. we are willing to have accountability in this bill, and that's why we put in that a requirement that a sample of the reports be reviewed. I don't believe that is done for other medical procedures, so this is kind of a step beyond what is normally done. Other states that have medical aid in dying review a sample, so this is based off of what is in place in other states that have it. They don't look at all of them. I don't see this as a terrible amendment, but I assume there would be a cost. I'd just like to know a bit more about it. I'm certainly willing to work with you on this as this moves forward, but I guess at this point I would ask members to vote no. But I'm happy to continue discussions on this topic.
Okay, Representative Quam.
Thank you, Madam.
Sorry, did Backer, did you want to follow up? Yes.
I could, if I could, Madam Chair.
Sorry, go ahead.
Thank you, Madam Chair.
Representative Quam, I couldn't see Backer, so
No,
I'll get you next.
I have pink on, that's fine, okay, so, but he has pink too, and we did not call ahead of time, even though we're dressed in pink. And I appreciate that, but MDH needs to review all of them. A sample is not good. That's why the EMSRB board reviews all the runs here in Minnesota. And you can verify that with the executive director, because I had a conversation with them this morning. So I would respectfully disagree. It is unacceptable that MDH does not review every data. We're not talking about huge number of numbers. I don't see why there would need to be another FTE on this at all, so it would not mess with the fiscal resources of MDH whatsoever. We're talking about ending a life. We've heard from testifiers that support this, that this is something that is dignity, and I'm not saying I agree with that or not in this content. I'm saying that these people deserve to, these individuals, another human life. We need to look at all the data, not just a sample, because as we know, samples can skew things. It doesn't matter their race, their color, their ethnic background. We need to look at all the data to see if there is if this does become law, if there are any patterns we as lawmakers and the state need to be concerned about. And the only way we can do that is if we look at all the data. And that's why I'm moving this forward and so forth. So thank you, Madam Chair.
All right, thank you. Let me just remind members too, this bill probably has quite a few committee stops ahead of it. Representative Quam.
Thank you, Madam Chair. And because this amendment has to do with data, and I've looked at, there's quite a bit of data that's present here, in the plethora of documents, but we're trying something new and different. And the quantity that we're talking about for review of all cases should be relatively small. What I've heard someone say 150 years of et cetera, frankly, it would be in the 2-digit as if it goes anywhere like the other data in here. But what I'm concerned about is if we don't have the data to appropriately analyze and address things, that there could be effects to different communities within our state. Because we see with anything having to do with health, there can be some disparities and effects. Plus, looking at the data just for Oregon, in a 2-year period, it doubled in the amount of prescriptions for this. So it'd be good to understand if there's a large increase, what's happening. And especially with this being such a real small number of cases, I don't understand why we wouldn't want to, when we start something new, have the data to be able to analyze, to improve or adjust as needed to best implement, because Minnesota has unique communities and isn't the same as some other states. So I would hope that we could actually agree that, yeah, we're going to collect data. Thank you, Madam Chair.
All right, well, seeing no further discussion, all
Madam
in favor
Chair?
of,
Yeah.
Representative Backer, sorry.
I'll be
I'm
brief,
sorry.
yes. It is so important to collect all the data, so I do ask for a roll call.
Okay, Representative Backer having requested a roll call. There will be a roll call. Ms. Niedernhofer. We're all a little out of practice here.
Yes, we are.
Can you hear me?
Included.
Yes.
All right.
Chair Liebling?
No.
Liebling? No. Vice Chair Bierman?
Bierman, no.
Bierman, no. Lead Schumacher?
Schumacher, aye.
Schumacher, aye. Representative Acom?
Acom, no.
Acom, no. Representative Backer?
Aye.
Backer, aye. Representative Bonner?
No.
Bonner, no. Representative Carroll?
No.
Carroll, no. Representative Elkins?
No.
Elkins, no. Representative Fisher, excused. Representative Livingston Yeager?
No.
Yeager, no. Representative Herr?
No.
Herr, no. Representative Keel?
Keel, aye.
Keel, aye. Representative Murphy?
Aye.
Murphy, aye. Representative Nadeau? Excused. Representative New Brindley?
Aye.
New Brindley, aye. Representative Perryman? Excused. Representative Quam?
Aye.
Quam, aye. Representative Ryer? No. Ryer, no. Representative Smith? No. Smith, no. There are 6 ayes and 10 nays.
There being 6 ayes and 10 nays, the motion does not prevail and the amendment is not adopted. There is an A5 amendment. Does someone want to offer the A5?
Madam Chair, I would like to move the A5 amendment to the DE, please.
Representative New Brindley offers the A5 amendment to the amendment.
Thank you, Madam Chair. And Representative Freiberg, the A5 amendment, basically, the reason I brought this forward, it changes the effective dates. And the reason that I brought this amendment specifically forward is that the department, MDH, actually has pretty significant oversight responsibility and reporting requirements. And that to think that, well, basically what the amendment does is it says that the language is effective 15 days following the completion of the forms and checklist by MDH and posting to MDH's website, which is all in the bill. But right now, as the underlying DE stands, enactment occurs on August 1st, regardless of whether or not MDH has had the time, staffing resources, whatever it is, to complete those forms. My concern is that by moving forward without those things, it is an indication that MDH may be underwater. It should be easy to create forms. And if they can't get forms done, they have other, like I said, important oversight, like the review of reports. They have a public report with summary data. And if they can't get a form done, how are they going to get these other things done? And I'm concerned about moving forward without those assurances. So really, all this amendment does is say that the effective date, rather than being August 1st no matter what, is 15 days after MDH completes the forms and makes them publicly available on their website.
Representative Freiberg.
Thank you, Madam Chair. Thank you, Representative New Brindley. This is another one I'm willing to work on, but at least at this point, I would ask members to vote no. I mean, I don't anticipate that developing this form would be a difficult process for MDH. I don't think, generally speaking, we should make a bill's implementation dependent on executive agency action. And beyond that, though, we just heard about how urgent this is for so many people. So at this point, I would not be supportive of this one.
Okay. All right. Representative New Brindley.
Thank you, Madam Chair. Thank you, Representative Freiberg. I guess I would just point out that the way my amendment is drafted, this actually could be enacted before August 1st if MDH gets it done. I mean, I would keep in mind that this is not
an amendment to delay implementation. It's an amendment to ensure that it's done right and that MDH has the ability to do the things that they are required to do in this bill. Members, I would strongly encourage accepting the amendment. And I guess, Madam Chair, I would request a roll call vote.
Okay, a roll call having been requested, there will be a roll call. Anything further?
I did have.
Representative Backer.
Pink guy.
You gotta
So,
reach
okay,
over.
thank you, Madam Chair. I think this is extremely reasonable in several professions outside of the medical field, just airliner. If you ever fly an airliner, they have operational checklists to make sure, and we all want to go on the airline that flies the friendly skies and lands safety. All professions have checklists because as individuals, we get busy, we get distracted, and we're talking about a person ending their life through a death that they're choosing, and we have to make sure the I's are dotted, the T's are crossed. When I go on a cardiac arrest run, we have a checklist we go through. Because as a volunteer, that pager goes off. I am doing other things, but we have to follow a checklist there. We all follow checklists. I suspect everybody on here maybe have a to-do list or something similar just on their day-to-day activity. So, Representative, this just makes common sense and reasonable sense that we have this type of checklist, which is a form. I'm referring to this as a form or checklist, so the right things are done for the Minnesotans who choose to follow this procedure if this becomes enacted. Thank you.
Representative Murphy.
Thank you, Madam Chair. Another concern I'd have with this is that the social workers aren't typically able to testify to any of these, but yet we're going to allow them to operate out with even having a checklist to go by. And so they typically aren't qualified, at least under, like I say, the court of law. So how do we overcome that if we don't have a checklist and we're starting the process?
All right, well, seeing no further discussion, the roll call having been requested, the clerk will take the roll.
Chair Liebling.
Liebling, no.
Liebling, no. Vice Chair Bierman.
Bierman, no.
Bierman, no. Leach Schumacher.
Schumacher, aye.
Schumacher, aye. Representative Acom.
Acom, no.
Acom, no. Representative Backer.
Backer votes aye.
Backer, aye. Representative Bonner.
No.
Bonner, no. Representative Carroll.
No.
Carroll, no. Representative Elkins.
No.
Elkins, no. Representative Fisher, excused. Representative Hemmingson-Yager.
No.
Hemmingson-Yager, no. Representative Herr.
Her, no.
Herr, no. Representative Keel.
Aye.
Keel, aye. Representative Murphy.
Aye.
Murphy, aye. Representative Nadeau, excused. Representative New Brindley.
Aye.
New Brindley, aye. Representative Perryman, excused. Representative Quam.
Aye.
Quam, aye. Representative Ryer.
No.
Ryer, no. Representative Smith.
No.
Smith, no. 6 ayes and 10 nays.
There being 6 ayes and 10 nays, the motion does not prevail. The amendment is not adopted. There is an A4 amendment. Does anyone want to offer the
Madam Chair.
A4? Representative Keel.
Thank you. Amendment A4 would require that both the attending and the consulting providers need to be physicians. I know that in the bill it refers to APRNs, which are wonderful people, work hard, have a lot of background, but when you look at all the other places that are doing assisted suicide, California, Colorado, Oregon, Maine, New Jersey, and Vermont all have requirements for 2 physicians. And as many of us know, I'll spare you all my personal stories, but more than once in my life, a doctor has said something they're sure of, and 6, 8 months later, they're wrong. And I think it is important that we have a physician, 2 physicians that coincide the information and let somebody know what's going on in their life, because, you know, as we're all human, we miss things. We see differences. We might recognize something that is changed. So we want to ensure the highest level of expertise so that the mandatory in the process is consequential, and Minnesotans that are making these decisions should be guaranteed that 2 physicians are both coming to the same conclusion, that this person, this individual, has a terminal illness, that they are medically capable of making the decision, and that their prognosis is fewer than 6 months to live. So I would encourage you to consider this a friendly amendment and something that I think that we should provide our Minnesotans with.
Representative Freiberg?
Thank you, Representative Keel. Thank you, Chair Liebling. I agree with everything you said about APRNs being wonderful people. They are highly qualified. They already have independent prescribing authority that's given by the legislature. So this is consistent with what they're already doing. And under the bill, at least one provider has to be a physician. And this was actually, this provision here was in fact a compromise. An earlier version of the bill allowed APRNs to do both roles. But I think this is important given the caliber of the qualifications that APRNs have. We also want there to be rural access, and that might expand it. And then just regarding the possibility, you know, of a prognosis being wrong, you know, predicting when someone will die is an inexact science, but certain diseases do have kind of a predictable trajectory, and that includes cancer and ALS, and those are the individuals who are choosing medical aid and dying. So I would ask members to vote no on this amendment.
Okay. Representative Keel.
Thank you. Well, I'm gonna throw a story in. My husband's classmate got ALS when he was fairly young, newlywed. He has lived 40 years with ALS. Unusual? Yes. Choices that they made helped him to sustain. His life is pretty limited, but he and his wife still managed to get him out of the house quite often, and other things that he's doing. A choice that he made, I would also point out. But I really think that the importance of hearing from physicians, APRNs, rural Minnesota, are very common. But I really think that somebody who is sick, has a diagnosis, needs to seek others, and in my world, you would have to travel to see another physician to get that second opinion, most likely. And while we don't, actually, when I think about it, we don't have that many APRNs either. But I really think this would give us the expertise, the backing that we need for this, and to protect the citizens so that they know what is possible and their expectations. You're right. Doctors are not going to know for sure. That is very inexact science. My own father-in-law lived 4 years longer than the doctor told us he would. And most of that was quality, not very difficult for him. He enjoyed farming still. And we didn't expect that at all. So I just really think that this is something we should consider.
Thank you. Representative Backer.
A question for the author. You know, other states like Oregon, California, and we've heard that this is modeled, built somewhat from that, does require both providers to be physicians. Why does your bill, what was the reason behind your bill that only one provider has to be physician? What would be some other reasons that you did that? I know you talked about access of care. We heard that with one of your answers here, but what would be some of the other reasons why you went that way instead of doing what Oregon and California did?
Representative Freiberg.
Thank you, Madam Chair. Thank you, Representative Backer. My understanding, and I can correct the record later if I'm wrong, but my understanding is there are 3 states that also allow APRNs to do this, to provide this sort of service. This is a medical procedure. This is something many doctors out there want to prescribe. We've heard from many of them. And, you know, this, as I said, prescriptions are something APRNs are also able to do. So I just think it's out of respect for the profession and out of access for this procedure. I mean, we heard Representative Keel say her constituents might have to drive a great distance to see a physician. And as I said, there is still a requirement that one of the providers be a physician. So there is still supervision by a physician as part of this process.
Nothing else.
Okay, seeing no further discussion, all in favor of the A4, please say aye.
Aye.
All opposed?
No.
The motion does not prevail, and the amendment is not adopted. There is an A8 amendment. Who would like to offer the A8? Representative Quam.
Thank you, Madam Chair. And, you know, frankly, this is just doing what, you know, originally even Oregon did, was restrict it to residents. We've had all the discussion about cancer and terminal illnesses. I grew up near the Mayo Clinic. I know so many people that Mayo was the 3rd, 4th place they went to, but they were terminal. And they were around years later. How many years ago did former President Carter have terminal brain cancer? And I saw him attend his wife's funeral just recently. And part of, I'm used to, you know, destination medical center. I'm used to it being a destination where there's hope and positivity. I don't want the state to be a destination for, and I won't mention the word, I prefer us being known and thought of as a destination of hope, because so many across the world come when there's little hope and their lives are saved and their families have their loved ones for years beyond. So if we do pass this bill in some form, at least starting out, I would like us to have it just for you know, people that have a ID, driver's license, et cetera, you know, that live in the state of Minnesota. And then we can look at things in the future like other states, you know, have looked before. But let's understand what unintended things may happen before we, you know, expand it like this. So that's why I think it's prudent for us when we take this step to take this amendment. Thank you.
Representative Freiberg.
Thank you, Representative Quam. Thank you, Chair Liebling. So states, the states that have medical aid in dying laws generally initially had a residency requirement, and I do say had in past tense for a point. In the last 2 years, 2 states have had residency requirements challenged in court, and they subsequently got rid of the residency requirement. I think there's an argument that those requirements are unconstitutional under the Interstate Commerce Clause. But kind of speaking more generally, we don't want to be in the position of allowing providers to prohibit some healthcare services from those who are out of state. I mean, just to name one potential problem with that, it can cause problems for people who live near the border and elsewhere. So I'm going to ask members to vote no on this, if you would.
Representative Quam.
Thank you, Madam Chair. You know, frankly, this committee on the other amendments, the public sees that we don't think data is important because we voted that way. We had another amendment. We're actually having the forms before you start doing something isn't important. And frankly, no matter what we do, we should start out in a manner that allows us to see what we need to tweak. I would be surprised if Oregon over the years hasn't done little tweaks and changes. And you heard discussion, and it's very personal for people. My wife has MS. She's had it for decades, and we understand, the future. I was there when my mother came home for home hospice for her end of life from cancer. These are difficult things, and emotions get into it. But when I look at an issue, I try to think of how can we start out and avoid other issues. That's why I wanted more data, and other things. I think it's reasonable to start out with just Minnesotans because it should be manageable. And I'd like to find out why Oregon doubled in the amount of prescriptions being put out in a 2-year period. I want to understand more fully this very important issue. And, maybe I'm being cautious, but frankly, I think we should be prudent and cautious and include things before we start out that would have us in a better situation to control something that pops up. So, again, I want Minnesota to be a destination of hope is the first thing that comes to mind, not a destination to come here to end life. But thank you.
Okay, thank you, Representative Quam. So all in favor of the A8 amendment, please say aye.
Aye.
Opposed?
No.
The motion does not prevail, and the amendment is not adopted. So we are back on the bill as amended, the 1930 as amended by the original author's amendment and the technical amendment. So discussion to the bill as amended. Okay, Representative Schumacher.
Thank you, Madam Chair. And my first question is for Representative Freiberg on this. It looks like there's been, it's clear that there's been a lot of work that's been put into this and a lot of examples and using what other states have learned about this as you were putting this together. It's my understanding that other states have a period when the requests are being put in, a pause in between when the first request is put in and when subsequent requests are put in. And I don't find that in the language here, and I was wondering if that was intentional and why that might have been.
Representative Freiberg.
Thank you. I think having Professor Pope come up here to talk about the experience in other states might be helpful because I know that has come up in those areas.
Sure. Sure, and if you would just, for the record, just say your name again into the mic.
Thaddeus Pope. So, I don't know who was talking.
Yeah, please, go ahead.
So originally, there was a 15-day waiting period. So the patient would have to make an oral request to the physician, and then 15 days later, make a second request, and then in addition to the 2 oral requests, make a written request. Most of the 11 states that have authorized medical aid in dying have moved away from that model. And the reason is because people don't start exploring medical aid in dying until very late. into their disease trajectory, so way beyond the 6-month line. And the consequence of that is they died or lost decision-making capacity before they could make their second request. So the 15-day waiting period ended up being what's called an undue burden or an obstacle to accessing medical aid in dying. So most states have either eliminated the waiting period, shortened the waiting period, or allow it to be waived if the physician certifies that her patient, can't last however long that state's waiting period is.
Representative Schumacher?
Okay, thank you, Madam Chair. That's the only thing I had on that. I don't have a follow-up to that. I have one other question. That's just on the process piece on a fiscal note. If one has been requested, when we expect to see that. I know we don't have one for today. Will this bill have to come back to us when there is a fiscal note? Just that question.
Yeah, I think that's more of a question for me, probably, Representative Schumacher. And I don't know if one's been requested on this DE. I guess I could ask fiscal staff that question.
Madam Chair, there is a fiscal note requested on the DE. It was amended slightly today. We'll have to modify that, but there is a pending fiscal note. But as you mentioned, this bill probably might have other things done to it in other committees.
Yeah, so Representative Schumacher, I mean, this bill probably has a pretty long path. I mean, it's going to public safety. From my eyes, it'll probably have to go to civil law, I don't know, other places too, I'm sure. And if there's any kind of significant fiscal note, we'll have to look at it again, because obviously we don't have that now. I kind of think in terms of our committee, the fiscal note, I'm guessing, wouldn't be very big, but still, yeah, we've got a long way to go.
Thank you, Madam Chair.
Okay.
Oh, and Madam Chair, I'd
Yes,
request a
Representative
roll call on the final vote. Thank you.
Okay, roll call is requested. So I have Quam, Backer, and New Brindley. Representative Quam.
Thank you, Madam Chair. And I noticed both looking at the last year for Oregon and looking at the composite across the whole period and all the states, that about 40% that receive a prescription for the meds do not pass by taking the meds. I also saw some analysis that a certain portion of those died before taking the meds, which was sort of hinted to. But there's a significant portion that isn't showing there. So how many ended up changing their mind, not taking the meds, and lived, past the expectation?
Mr. Pope?
Representative Crum, you're right that 30 to 40% of patients who get the medications do not ingest them. But I wouldn't characterize that as changing their mind. Most people get the medications, as you heard some of the testifiers, kind of like we all have fire insurance or home insurance. Like, we have it to give ourselves peace of mind and comfort, but we hope that we don't have to use it, right? And so these patients get the medications in case their physical or existential suffering becomes unbearable. But many of them, as you noted, 30 to 40% of them, the hospice and palliative care that they're getting is perfectly sufficient to address that suffering, and then they don't need the medications. They're there just in case.
Representative Kwan.
Thank you, Madam Chair. Then I have some concerns, especially since we're not collecting full data, that there are drugs out there that are designed to end a life, and we don't know if they're used or not. We don't know what happens to them. And frankly, I think there's a case down in our area, Madam Chair, of where a physician is being on trial for using a medication on a different person that ended up causing that person to die. So, I am not feeling a warm fuzzy by the lack of certainty of, we're introducing stuff out there. And when I looked at the data, it looked as if a good 10% didn't fall into the category, out of that 40, actually it's like 36.7, something like that percent, that didn't take it, so it's out there, over a third. And then the people that didn't die within the normal time or pass. I'm just concerned about, we're introducing a very dangerous thing into the population that's out there, and after someone dies, say they die in hospice and they didn't take it, I don't want the risk of a family member who's depressed and traumatized by that death seeing this in front of them and maybe using it. And who knows what else could happen with. So I'm not seeing in this bill, one, the data, the collection and analysis to prevent, a third of this medication being out there, and these unforeseen things. So is there any reassurance you can give me about this queasiness?
So there's something in the bill, right? Representative Freiberg, why don't you go ahead?
Yeah, I was going to mention that. There is, if you look to line 10.25, there is a requirement for safe disposal of unused medications. And Dr. Carroll is up here, too. He does have relevant experience from Colorado, if you're interested in hearing about that.
Okay. If we do, if you want to hear
Madam Chair, if we're not collecting the data and we don't have the forms and et cetera, I don't see any confidence that we would be able to even know, let alone enforce the disposal of it. If we're going to do something, let's do the due diligence to make sure that an unintended person doesn't die because we didn't do the appropriate due diligence.
So I think Representative Quam, we'll go to Dr. Carroll. Carroll, right? And but let me just say that I think there are plenty of drugs that are very dangerous that we don't have once they are prescribed and they're out there. There's plenty that people can and do get into. But with regard to this, Mr. Pope,
Yeah,
who
this
wants
is
to
Thaddeus
respond?
Pope. I'll respond, and then Dr. Carroll will make. I think this might help you a little bit, Representative Quam, is the way medical aid and dying typically works is the patient gets the prescription. It's just a prescription. It's not the drugs themselves. The drugs that are almost always used for medical aid and dying is a compounded drug, and almost always the patient doesn't obtain the medications themselves until they're ready to ingest them. So it's not the case that there's all these unused lethal medications in people's houses.
Dr. Carroll.
Yes, Madam Chair, Representative Quam, this is Dr. Corey Carroll. In Colorado, and as Thaddeus Pope mentioned, there is a organization that helps to educate physicians. I also do it, and our guidelines are to, when patients qualify, I actually tell them, I really don't want you to get the prescription. However, when you need it, I can get it to the pharmacy, I can send it electronically, you can take the prescription in if you want. So you're correct that some of the data is, to collect all the data on everything is impossible. However, physicians know this. Physicians do not, again, this is the last thing I want to do for my patients. And I tell them, I hope you don't need this, but if you need it, let me know. I will get it to the pharmacy, we'll get it to you in a timely fashion. And these are not emergency processes. These are things patients have thought about sometimes for decades. So once again, they qualify. That doesn't mean they have the prescription in hand. Some do require it, and I actually tell them you have to lock it up, and I or the hospice nurse will take care of it if needed, if it's not used, et cetera. So there's no reports that anything's gone wrong.
Okay.
Madam Chair, just quickly, the clarification that most medicine and prescriptions are not designed with the intent to kill. So there is a distinct difference. And secondly, we have nothing in this bill to ensure that something untoward doesn't happen. and that's all I'm asking for. Thank you, Madam Chair.
Representative Backer.
Couple questions. Thank you. And this is for Representative Freiberg. Has there been documentations of the complication of the medication used to end a life? Has there been any documents, because we've had plenty of deaths by pills, that there was any complications? How many pills are needed? And once it's taken, the average time would be my first three questions. Any complications for this? Because there are counterindications for drugs out there.
Dr. Carroll.
Correct. Representative, Madam Chair, thank you for that question. The phenomenon of complications is present in basically everything. The data that I know, and the American Clinicians Academy of Medical Aid in Dying does collect data. Again, there's multiple states that are have this in practice. There are documents of some seizures that occur. There's documentation of prolonged time to death, but to my knowledge, no data or documentation that showed that the medicines have not completed the task of allowing that patient to die.
Representative Backer.
Okay. Generally speaking, once they take the medication, that was a question there, are we talking about, is it a 20-minute process? I've heard from testifiers, but I would rather hear from a professional. They go into supposedly a natural, not natural, that's the wrong choice of words. They go into a sleep and then does it quit the respiratory, or is it a stop process that stops the heart from beating? What does that medication do?
Dr. Carroll.
Madam Chair, Representative, the combination medication which is commonly used is a combination of 5 medications. The bottom line is they're in large quantities. They are designed to depress the respiratory centers in the brain and to decrease cardiac output and performance. So yes, however, the initial phase of the medication, and again, the document, I don't have that right at my disposal, but the time to sleep is roughly 5 to 10 minutes, some as quickly as 2, others go to 15, but on average, around 80% are going to be asleep within 5 to 10 minutes, and about 80% are going to be dead in 2 hours or less. And there are a few outliers, but the majority have a peaceful, quiet end and termination. And again, the medications work slowly. The variability depends on the patient. I have a patient with ALS who was a lacrosse star, and that's what he got a scholarship in. He exercised all his life. Well, ALS affects the neurons, but not the heart, not the liver, not the kidneys. So I've counseled that patient that if and when you choose to take the medication, there may be a protracted death due to the health of the organs in the body. Other patients, the lady with glioblastoma multiforme, 18 minutes and she was not breathing. So lots of variability, but the medications work as intended, and in this intent is to let the patients have a peaceful death.
Yep, thank you. Continue questions, if I may, Madam Chair.
Okay, and then we'll get to Representative New Brindley. Go ahead, Representative.
Yep. This is for the author. Why are social workers included in the definition of mental health professionals in this bill?
Representative Freiberg.
Could you point me to the line of the bill, please?
Thank you. Okay.
I'll see if I can find it.
Subdivision 8, line 2.7.
Say that again?
2.7.
Yeah. Thank you.
Okay, I found it. Thank you. It's line 2.7.
Yeah.
So this is pretty common. This is in other states that allow medical aid in dying. This is part of what they do as clinical social workers.
Madam Chair.
Representative Backer.
Yeah, I would
professionally disagree with the author. Social workers, in my understanding, are not in that capacity to pronounce that. I know that for a fact because when social workers do health checks and there's a patient that is suffering a medical emergency, at least in the call area that I receive, they dial 911 for our ambulance crew to show up. So that needs to be changed. That would be poor to keep that in there, to have social workers included as the definition of medical health professionals. That would just be one reason why I would not support this.
Representative Freiberg.
Yeah, thank you. Social workers who work with the terminally ill do have the necessary skill set. 4 states do include them. Several states have added them, frankly, because the mental health service system is stretched.
Yeah.
Madam Chair.
Representative Backer.
Again, I would professionally disagree with that. The mental health is stretched. That is why deputy sheriffs and us EMTs and paramedics are called upon so much. Social workers are not trained. I'm not even trained as an EMT for medical health. I just have had the experience over the years due to, unfortunately, the School of Hard Knocks to be able to handle people with mental illness. And I do not mean that in a negative connotation. We are talking about folks that are looking to end their lives. I have been on easily, and I did not get the time to go through every runs, on over 100 runs, people that I get a page that they have attempted to commit suicide as an EMT. Those individuals have done that because they are in the lowest part of their lives. And quite frankly, members, I've never had one of those people who have came to me out, I mean this respectfully, said, I'm glad you didn't show up. They are happy that I showed up, provided medical care. And that's been well over 100 times. And I think I'm being very conservative at that. Because when people attempt to commit suicide, and I'm not talking about just the young, I have seen all ages, all demographics, all that what seems bleak at one time in their lives, and respectfully to the doctor there, what seems bleak at that one moment is not bleak. I've been on several runs, many, hundreds of runs, because I live in a population of well over 65. We are the most elderly county in the state of Minnesota. So I've been on several terminal runs, patients that have terminal illness. I remember a teacher on a Friday night. Her name was Eva. We took her to Wheaton. And I'm glad I had that opportunity. The most recent run was back last year on December 23rd. When the pager went off, quite frankly, I did not have a very good attitude, folks. I thought, why am I being paged out on a blizzard to a hospice patient, terminally cancer? Okay, we were in blizzard. That run, normally it takes 45 minutes, took us over 2.5 hours because of the condition. I was in the back of the ambulance with her. And I was glad that I could provide that care. I have only prayed twice in the back of the ambulance with a patient, and that was one of the 2 times. And she was happy that I came and provided her care. I actually got more from that run that I provided to her. She gave me an attitude adjustment that night, okay? And I mean that sincerely. There are times that pager goes off, I'm busy with this, and again, we have a blizzard. And quite frankly, the day before I was on an ambulance run, and we buried the ambulance because we got stuck on another run. So I really believe, and I respect you as a representative, working, I know you've worked on this, but in my opinion, this is a misguided answer to a real human problem. It's care that these individuals need. This is not medical aid. It is to die. That means it is not medical. It is to do harm. When you end a life, you're doing harm. And another concern that I have about this bill is we have seen that when we pass assisted suicide, assisted death, the regular rate of suicide goes up. That means folks like me in my profession, we're going to be handling more calls. We can do better. this is a misguided answer to a real human problem. So thank you, Madam Chair.
Representative New Brindley.
Thank you, Madam Chair. And first, Madam Chair, I'd like to just say thank you for allowing the hearing to go a little long so we can have our questions answered. I do appreciate that. I've got some questions specifically regarding language in the bill. And on the first page, line 1.13, you're talking about a consulting provider. You say who is qualified by specialty or experience. I mean, we all can understand, I suspect, specialty. How is experience defined?
Representative Freiberg.
Thank you, Madam Chair. Thank you, Representative New Brindley. I mean, it says that they are qualified by specialty or experience to make a professional diagnosis and prognosis regarding the individual's terminal disease. And I'm trying to locate the provision that provides further elaboration on the requirements of the consulting provider.
I didn't see additional clarification on that.
This is Professor Pope. I mean,
Pope.
it's very common, right, that clinicians will have experience to opine or to make diagnoses and prognoses with respect to something, even if they're not board certified in that area, right? So the most common reason people use medical aid in dying is cancer. Typically, your cancer prognosis would be made by an oncologist, a board certified oncologist, but there could be somebody who's not board certified in oncology who, based on their experience with cancer, even though they don't work as an oncologist, would be qualified to provide the cancer diagnosis.
And Dr. Carroll?
Madam Chair, Representative, whenever a patient comes to me and I am not clear of a diagnosis, I seek information, and that includes blood work, and that includes imagery, that includes medical records. And I can tell you of all the patients I've taken care of and my colleagues have taken care of, this process occurs over weeks to collect the data, to collect the biopsy result, to collect the MRI scans, the CT scans, the consult notes, to call the physicians. None of this is done in an emergency. None of this is done accidentally. This is done with intent, and there is no doubt, we made the point that physicians do sometimes overestimate prognosis, but there's no doubt that the diagnoses that we're providing is accurate based on the current standard of medical care. And again, I have never taken this lightly, and there's no way any of my colleagues are going to have a patient come to us and not obtain data, including biopsy results, consults, scans, and usually talk to the other physicians to qualify and make sure things are correct, if I don't know the patient myself quite well.
Representative Freiberg.
Thank you, Madam Chair. I did find the language I was looking for. It's on line 8.11. It specifies that the consulting provider has to be a doctor of medicine if the attending provider is an APRN. So it's either going to be an APRN or a doctor of medicine or osteopathy. The word experience in there is, I think, intended to prevent doctors who don't have end-of-life care experience, like dermatologists or doctors along those lines.
Okay.
Madam Chair.
Representative New Brindley.
Thank you, Madam Chair. I would just point out, number one, thank you, Representative Freiberg. I would suggest making that language more clear, because right now it is not clear, and it could be broadly interpreted, which would be a problem. I would also suggest it's a little odd. I appreciate, Dr. Carroll, your diligence, and I, of course, believe all of that to be true. But we were told earlier in this hearing that a 15-day period between consults is too much, and just now we were told none of this is done in an emergency. It takes weeks to get the information, so a little bit of a disconnect there. I would just echo the remarks about a clinical social worker. That actually is not included in Oregon, and I would encourage folks to read the letter from the Minnesota Psychiatric Association. It says social workers and counselors are not allowed to make capacity assessments in other medical areas. Like, this is a significant change from standard practice right now. They're not even allowed to testify in court. So that is a really significant change in this language versus standard practice among social workers. And sort of flippantly, we were told, well, mental health is stretched. So my feeling is we are literally allowing people to end their lives. This is the last situation in which we should lower standards just because we are stretched. My next question, mentally capable, you define mentally capable as has the ability to make an informed decision. And I'm wondering if that's on lines 2.15 and 16. And I'm wondering if you can expand on that just a little bit. And perhaps this would be for the physicians more appropriately. You'd probably have experienced this more. But what are what would be some of the red flags, some of those mental issues that would prevent someone from qualifying for assisted suicide?
Dr. Carroll?
Madam Chair, Representative, in the time that Colorado's had the law, I've had several patients reach out to me that weren't my patients, and it became obvious right from the start that they would not qualify. So the argument of mental capacity is having the individual understand what the diagnosis is, what the prognosis, and have the capacity to see and understand the options, including aggressive treatment, including hospice, including palliative care, and including medical aid in dying, and being able to return to the physician or whoever's asking the questions that understanding and capability of saying, yes, I understand. If I take these medications, I will go to sleep and I will die. So there's 4 components, and one of the testifiers provided those for you. Again, this is what physicians do every single day. And when patients come in, I mean, if I have a patient coming in who I've known, and that's what I'd like to do, but I'll guarantee you in Minnesota, like in Colorado, the physicians that want to provide medical aid in dying are going to have a lot of work to do, and that's part of my role at Compassion Choices in the American Academy. But and when I gave you that number of identifying data, this is on people I don't know, but I've taken care of patients for 30 years. I have known everything about them, and I have counseled them when they had their prostate cancer and their lymphoma, and they've had their shoulder replacement. And there's no doubt in my mind who these people are and what they're going through. And so that's the ideal, that the physician that knows the patient, and in this case, mid-levels may have a better understanding of those individuals than physicians because that's who they've seen all the time. But the bottom line is, if that's the case, I don't have to question whether this patient is making good choices. If I do find a patient seeking me out because they can't find any provider in their hospital system due to the policies of the hospital or the philosophy of the physician, then it's my due diligence to take the time, and I am not going to make a mistake on that. And over the years in Colorado, approximately of the 19 patients I've helped, around 9 were new to my clinic. And it was 2, 4, 6 weeks to understand them, to meet with them, to meet with their families. And I don't think that's unique to my practice. That is, once again, I was talking to the medical students when they left here, and I tell you, we don't go to medicine to do this. This is the last thing we want to do. But it is inevitable in many of these cases. And when I've watched my patients over 30 years at the end of life, some who want this, it's a godsend. I have others that would never choose it, and that's perfectly fine. I have colleagues that would never prescribe. That's perfectly fine. There's no compulsion in this law. There's no compulsion in the other laws. So hopefully that answers your question, and I apologize for pontificating a bit.
All right, one more, Representative Brindley. We're half hour over, and I think we're.
I'm happy to stay to get. I'll stay as long as we need.
Well, you may, but our staff may not. I don't.
So there is no requirement to consider the mental health of the individual, exclusively their ability to make an informed decision and to understand the decision they're making, unless I missed that in the language.
I think that's, I'm sorry, this is Professor Pope. I think that's actually, it's actually robust in the language. I mean, both the attending clinician has to determine that the patient has mental capability and understands this option and understands her other options. The consulting clinician has to do all of those things as well. And then if either of them is uncertain about any of that, then they have to refer to the mental health specialist. So it's at least 2, possibly 3 clinicians are assessing this.
Representative Freiberg.
Yeah, the language is on line 9.14, just requiring them to certify that or determine that they are mentally capable.
Yep.
Madam Chair.
Okay. Representative New Brindley.
I understand that it says that they must be determined medically capable, but we were just told that medically capable is defined by their ability to understand the choices they're being given and be able to tell that back to the physician. That the definition in this language makes no requirement about the mental health of an individual. It exclusively in this language, and what we were just told is about their ability to understand. It is not about their mental state at any given time. I think that's really important to address. I also, as many people in this room have testified, have spent a great deal of time with people end of life. I worked hospice myself. I, 2 years ago, was with my brother when he passed away. I cared for my husband with ALS for 3 years before he passed away. I have spent a great deal of time with people in the end of life and in these final stages. And I have great concern over the way we are moving forward with this bill and this language by not addressing things like that. It is one thing to be able to understand informed consent and give informed consent. It is a different thing entirely to determine one's state of mind and mental health in making that decision. And that is not required in this language. That is not required in this bill language. I would also suggest, Representative Freiberg, that you consider Representative Backer's amendment of reviewing each case. There is good language in this bill about ensuring that there is no coercion, about ensuring safe disposal of medications that are not used, of good faith compliance by providers. Those are really important provisions, and I appreciate that those are in this bill. But if we are not reviewing each case, there is no way to know if those things are being complied with. There's just no way to know. We need to know these things. And again, you know, I mean, we were just told that it is likely that the Department of Health, that the cost will be minimal. They should be able to do these things without really an additional cost. We probably won't see much of a fiscal note. Well, if that's the case, then there should be no reason to implement this bill before the department can create simple forms and checklists. Again, we are talking about giving physicians and individuals the ability to end their lives. And if we are going to move forward with this, the very least we should do is make sure that we are taking every care and every precaution to make sure that it is done right. Thank you.
So I would say, I'm going to go to Representative Acom, but I'm going to, hold on one second. Let me just say, though, there is time to work on this bill, and I appreciate the close reading and the careful thought that Representative New Brindley and others, are putting into this. What I would say is, this is the process that we should have on a bill that is an important, meaningful bill. Well, Representative New Brindley, what I'm about to say is, with the bill actually, until we're in session, the bill doesn't move. If you work with Representative Freiberg and can come up with some other, working together, we can make improvements to bills.
So we don't want the public to know the questions about the language.
Well, Representative New Brindley, calm down. We're in committee here, okay? Could I, talking. We're not, Representative Brindley. I have the floor, Representative New Brindley. And what I was about to say is that we could bring the bill back if you reach some agreements, and we could bring the bill back to committee before it even goes to moves on the floor, and make some changes. So that is a possibility for this. So this is not the end of a process. It really is the beginning of a process. So, Representative Acom.
Thank you, Madam Chair. Excuse me, and thank you, Representative Freiberg, for bringing this bill forward. I will say, we have heard from so many people today about how challenging and hard it is to lose their loved ones, and especially when the end of life is hard and they are struggling and suffering, honestly. And I come to this committee today, and I come to this this bill as a primary caregiver for my husband, who has advanced multiple sclerosis, and while likely would not qualify for this today, will likely at one point in his life, however long he has left. He suffers every day with pain and with his body fighting him. And he is stronger than anyone I know, because he gets up every day and he fights. And he does that because he wants to live. He doesn't want to die. He wants to be around to see our children grow up. He wants to be around to see our children marry and, move on in their lives. His condition and he has exhausted every medical possibility and hope. And unless new things come along, there are no other options medically for him at this point, and it is a matter of time. It gives him great anxiety to not know what the future will hold, and to not know that to maybe not, I shouldn't say not know, but to have that uncertainty of suffering in the future. And when he and I have talked about this bill and this option, it brings comfort to him to think that that could be a possibility, and it gives him renewed efforts and energy to keep fighting. And so I know that this isn't easy. I know this is an emotional issue for everyone, and I'm so impressed by the respectful dialogue that we've had here today. And I think this is really important. This is an option, and this is a choice. And so I thank you for bringing this bill forward. I thank you all for the discussion today, and I hope you'll join me in supporting this bill.
Final word, Representative Freiberg, then we'll go to a vote.
Thank you, Madam Chair. Thank you, members of the committee. I really do appreciate the respectful dialogue. Thank you for sharing your story, Representative Acom, and thank you to everyone in the audience who's done the same. I know it's really hard. I'll be brief, but I would like to respond to a few points made during testimony and member questions. So first of all, I agree with the testifiers about the need to invest in healthcare access. I appreciate the work this committee has done in this regard, but there is still much farther to go. But that doesn't mean we should prevent a proven healthcare option that can help prevent suffering and advance bodily autonomy. There was a statement made that medical aid in dying will be targeted against people of color, but the vast majority of people who use medical aid in dying in states where it's authorized are not people of color. There was a reference to the American Medical Association's position, but that statement tells only half the story. The AMA position presents one perspective that, quote, powerfully expresses the perspective of those who oppose, end quote, medical aid in dying, but it has a counterbalancing position that articulates the thoughtful moral basis for those who support medical aid in dying. And this is consistent with the position of the Minnesota Medical Association, which is one of engaged neutrality, which was the phrase used earlier. Disability is not a qualifying condition for medical aid in dying. See line 3.24 of the Delete All Amendment. Suicide rates have been mentioned, but suicide rates went up in every state during the time cited in one state. There's no causation between this bill and suicide rates. The provision related to licensed mental health professionals applies only to clinical social workers, which may or may not be what you think of when you think of social workers. Clinical social workers have specialized medical training. So in summary, this bill is tested. The language is based on language from other states, which has been tested and proven to be effective. This bill is consistent with our efforts during this biennium to protect bodily autonomy. I don't agree with the Libertarian Party about much, but I thought the remote testimony from the representative of that party was compelling and explained why both Democrats and Republicans should support this. And Republicans and Democrats do support this. Sometimes it takes a while for the views of elected officials to catch up, but I'm hoping that members of this committee will please support bodily autonomy and vote in favor of the bill.
Thank you, Representative Freiberg. So they're having a roll call has been requested, so I will renew my motion to re-refer House File 1930 as amended to the Committee on Public Safety, Finance, and Policy. And so Ms. Niedenhofer will take the roll. The chair votes aye.
Chair Liebling, aye. Vice Chair Bierman.
Bierman, aye.
Bierman, aye. Leach Schumacher.
Schumacher, no.
Schumacher, no. Representative Acom.
Acom, aye.
Acom, aye. Representative Backer.
Backer, no.
Backer, no. Representative Bonner.
Aye.
Bonner, aye. Representative Carroll.
Aye.
Carroll, aye. Representative Elkins.
Aye.
Elkins, aye. Representative Fisher, excused. Representative Hemmingson Yeager.
Aye.
Hemmingson Yeager. Representative Herr.
Aye.
Herr, aye. Representative Keel.
Keel, no.
Keel, no. Representative Murphy.
No.
Murphy, no. Representative Nadeau, excused. Representative New Brindley, excused. Representative Perryman, excused. Representative Quam.
No.
Quam, no. Representative Ryer.
Aye.
Ryer, aye. Representative Smith.
Aye.
Smith, aye. 10 ayes and 5 nays.
There being 10 ayes and 5 nays, the motion prevails, and the bill is passed and on its way, sort of on its way, to the Public Safety Committee, because let me just say that, of course, the conference report could not move until we get back into session. And so as I said to Representative New Brindley, there is actually opportunity, if there are changes that need to be made, we could do them before the bill, before the before the committee report actually would go to the floor and be adopted on the floor. So just with that comment, thank you very much, members, for your patience and coming in and making the trip and for your attentiveness for this very important issue. And with that, we are adjourned.